शुभं करोति कल्याणम् आरोग्य Check, 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 sound check, check, check. Hale, 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 sound check, 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 check. Hale, 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 check, check, check. चेक, चेक, चेक। ऐसा नहीं होना चाहिए। अ, परसों तरसों भी लगा हुआ था, ऐसा हो नहीं रहा था, क्या दिक्कत आ रही है? चेक, 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 चेक। हाल, 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 हाल। नहीं। चेक, 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 चेक। हाल, हाल, हाल। चेक, चेक, चेक। हाल, हाल। चेक, 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 साउंड चेक, चेक, चेक। नहीं, फोनो नहीं है मेरे पे। चेक। चेक। मास कितना आउट कर रखा है? चेक, चेक।
आउटपुट नहीं आ रहा। बोला नहीं होगा ना।
चेक
हेलो चेक माइक टेस्टिंग। हेलो हेलो चेक चेक 1 2 चेक माइक टेस्टिंग। खोलो इसको। हेलो हेलो 1 2 3 4। हेलो हेलो चेक माइक टेस्टिंग 1 2। हेलो चेक माइक टेस्टिंग। चेक। हेलो हेलो इस माइक को बढ़ाओ सर। हेलो 1 2 चेक चेक चेक। हेलो 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 चेक माइक टेस्टिंग। हेलो हेलो चेक चेक चेक। हेलो हेलो 1 2 3 4 टेस्टिंग। हेलो चेक 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 चेक। हेलो हेलो 1 2। हेलो 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 चेक 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 चेक। इसका ऑडियो कम रखिएगा क्योंकि लैपटॉप से तो हाई आता है, उसका थोड़ा कम है। बाकी माइक का खोल दो। 50-50। हाँ माइक का बढ़ा दो। हेलो चेक माइक टेस्टिंग 1 2। हेलो 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 चेक 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 चेक। हेलो 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 माइक टेस्टिंग। हेलो ऑडियो टेस्ट। हेलो हेलो चेक 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 चेक। And then oh wait. That I completed from May June. Yeah, after wedding, that's very nice. उसमें I industries और तो आप 12:30 बजे speaking और हम लोग हाँ, yeah.
यानी आज की डेट में दिखाना है बस for 2 months. आज की डेट में for 2 months date. ठीक.
Good morning, ladies and gentlemen. I, Ms. Shreya Srivastav,
I, Dr. Richa Verma,
on behalf of the Ministry of Health and Family Welfare, Government of India, welcome you all. It gives us immense pleasure to extend our warm and heartfelt welcome to all in order to celebrate the 6th World Patient Safety Day on this beautiful morning. In healthcare, patient safety is of utmost importance. To address this critical issue, we have gathered here with healthcare strategists, patient organization from civil society, policy makers, program managers, healthcare facility leaders, direct care providers, as well as patient families and caregivers.
देवी और सज्जनों, इस महत्वपूर्ण अवसर पर आपकी उपस्थिति ने इंडिया हैबिटेट सेंटर के इस सभागार को और भी भव्य बना दिया है.
Envisioning a world where healthcare causes no harm and every patient consistently receives safe and respectful care, the issue of patient safety has emerged as a critical global challenge. Acknowledging this, the 72nd World Health Assembly in 2021 adopted the Global Action on Patient Safety Resolution, prioritizing patient safety as a critical component of the Universal Health Coverage Agenda.
विश्व रोगी सुरक्षा दिवस हर साल 17 सितंबर को मनाया जाता है, जिसका उद्देश्य मरीजों की सुरक्षा के प्रति जागरूकता बढ़ाना है। प्रत्येक वर्ष एक विशिष्ट थीम चुनी जाती है जो प्रमुख रोगी सुरक्षा चुनौतियों को संबोधित करती है, जिससे जागरूकता बढ़ती है और स्वास्थ्य देखभाल प्रणाली में सुरक्षा को बढ़ाने के लिए वैश्विक प्रयास को प्रोत्साहन मिलता है। इस साल की थीम है इम्प्रूविंग डायग्नोसिस फॉर पेशेंट सेफ्टी, यानी रोग निदान में सुधार के जरिए मरीज सुरक्षा, जो निदान की सटीकता और समयबद्धता की महत्वपूर्ण भूमिका पर प्रकाश डालती है।
Diagnostic errors, which are often overlooked, accounts for approximately 16% of patient harm. This statistic highlights the urgent need to raise global awareness about this issue. Our goal is to make patient safety a top priority in healthcare policies. By fostering collaboration among policymakers, healthcare leaders, health workers, and patient organizations, we can ensure accurate, timely, and safe diagnosis.
The Ministry of Health and Family Welfare, Government of India, has launched several initiatives under the National Health Mission to improve patient safety. The National Quality Assurance Standards address various aspects of diagnostic, clinical, and patient safety, including the evaluation of the National Health Program. Additional initiatives include Kayakalp, which focuses on cleanliness, infection control, and waste management to benefit both patient and community. Mera Aspatal, which empowers patients and caregivers through feedback mechanism.
To commence with today's event, we welcome all our key dignitaries. Ms. Aradhna Patnaik, Additional Secretary and Mission Director, National Health Mission, Ministry of Health and Family Welfare, Government of India. Major General Professor Atul Kotwal, Sena Medal, Vishisht Seva Medal, Executive Director, NHSRC. Dr. Neha Garg, Director, National Health Mission, Ministry of Health and Family Welfare, Government of India. Dr. J.N. Srivastav, Advisor, Quality and Patient Safety Division, National Health Systems Resource Center.
हम अपने साथ प्रतिष्ठित अतिथियों को पाकर सम्मानित महसूस कर रहे हैं, जिन्होंने स्वास्थ्य देखभाल नीतियों और प्रथाओं को आकार देने में महत्वपूर्ण भूमिका निभाई है। मैं सभी सम्मानित अतिथियों से अनुरोध करती हूं कि वे आगे आकर दीप प्रज्वलित करें।
शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाम् शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाम् शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाम् शत्रुबुद्धिविनाशय
मैं सभी अतिथियों से मंच पर स्थान ग्रहण करने का आग्रह करती हूँ।
Now, I would request Dr. J.N. Srivastav, Advisor, Quality and Patient Safety Division, NHSRC, to please deliver the welcome address. Over to you, sir.
A very good morning to all of you. And at the outset, I extend a very warm welcome to Srimati Aradhna Patnaik, Mission Director, National Health Mission, Government of India, Additional Secretary, Ministry of Health, Major General Professor Atul Kotwal, Executive Director, National Health System Resource Center, Dr. Neha Garg, Director, NHM, and also the focal point for the NQAS, Kayakalp, and both the directors, Mr. Harsh Mangla, Dr. Saroj Kumar, Dr. Hilde, Dr. Anuradha Jain, ex-colleague, and my colleague, Air Commodore Ranjan Chaudhary, and all of you coming from the states. Ma'am, we have got the representation from 22 states, about 55 participants are here. In addition, we have got people coming from academic institutions, non-government organizations, development partners like WHO, USAID, UNICEF, and the people who have been working in the field of patient safety, including daily promotion for rational use of drugs, Dr. Sangeeta Sharma, and Academy of Hospital Administration. Cross-cutting the people are over here. It shows the importance to this topic. The patient safety, when we talk, when the patient, any patient who comes to us to visit, say, health facilities, or we are reaching out to the patient in providing the ambulatory care to them, particularly when we look, the focus of the Ayushman Arogya Mandir under NHM has been to reach out to the patients, provide the care which they deserve, whether within the facility or they're in home setting or in the community setting. But we also know that patient safety cuts across many dimensions, whether it is the issue of the medication safety, because we know that number of the prescription drugs, as the age advances, as the longevity of the life increases, are increasing day by day. And kidney functions, liver functions may not be in the true sense in the failure, but they become suboptimal. So that is one challenge. Secondly, hospital-acquired infection, healthcare-associated infections have been challenged. Like in the country, rough estimates are, the figure varies between say 12% to 20%. It could be anybody's guess. In addition, like in the primary healthcare setting, in the ambulatory care setting, the rough estimate is that about 3 to 4 patients, they encounter some kind of injury. Unfortunately, we don't have the figures pertaining to the Indian setup as such, but the rough estimate in a study conducted by Professor Ashish Jha a couple of years back was that about 53 lakhs patients, they encounter some kind of harm. And keeping this perspective in mind, the World Health Assembly, like my younger colleagues, they mentioned, passed the resolution. But before that, ma'am, the India has been one of the countries where we have the National Patient Safety Implementation Framework much before when the global resolution got passed. And because of the COVID, it could not be implemented in a formal way, but the government has been undertaking the efforts, and different dimensions, different subcomponents of the National Patient Safety Implementation Framework are getting implemented, and a lot of them, they have been incorporated, integrated as a part of National Quality Assurance Standard. And ma'am, this has been your focus of the ministry and the government as such, that every health facility needs to be NQAS certified, National Quality Assurance certified by December 2026, and that is a challenge also. And I take this opportunity to request all the states, the development partners, and people coming from the other organizations that we need your support in rolling it out. And particularly in the states where your presence is there, this is much needed. We'll talk in detail when I come back with the technical session. At same time, every year, a theme gets chosen by WHO, by the global body, that would be the focus area. In the previous occasions, we have had the theme taking care of the healthcare workers, safe RCH services, medication safety, and hearing the patient's voices. That was the theme last year. I mean, engaging the patients. Because when we talk about the health, patient, families, communities, they are an important people in the producing the health for the families, for the communities. And this year, the theme chosen is the diagnostic service. We all know that the ministry under National Health Mission has been supporting all the states in terms of rolling it out, reaching the free diagnostic service initiative. But it is not only the making those diagnostic services available, having the reliability, having the trust factor. That is another challenge which we are faced with. What happens, we all must have encountered that when a patient X travels from, say, peripheral facility to a apex institution, all sets of the investigations are ordered again. Besides delay in the diagnosis, it also results into certain out-of-pocket expenditure. How do we ensure that our, say, people sitting at the top level, they develop the trust factor in the diagnostics, in the investigation reports which are coming from the peripheries? So these are the couple of challenges, and with the operationalization of IPHL, Indian Public Health Lab, where under PM Abhim and under other NHM initiatives, gradually the numbers are increasing, but they got to be integrated, and I mean the work never ends. So I'm stopping over here. Once again, I'm extremely grateful to Madam Aradhana Patnaik. I know ma'am has many competing priorities. There is in parallel, the meeting is ongoing in the ministry, but ma'am, you have taken time out to be with us. That is a big source of encouragement for all of us and for our colleagues who have come from the state. Thank you very much.
Thank you so much, sir. With this, I would request my colleague, Dr. Chinmay Swen, to please welcome Ms. Aradhana Patnaik, Additional Secretary and Mission Director, National Health Mission, Ministry of Health and Family Welfare, Government of India. Since ma'am has taken responsibility, national quality assurance standard certifications have increased exponentially from 6,000 to approximately 14,000. Under her guidance, virtual assessment of Ayushman Arogya Mandir Sub-Health Center, integrated public health laboratories, and the revision of the Kayakalp initiatives have been rolled out successfully. Her dedicated efforts and strategic vision have significantly contributed in strengthening the healthcare system. We are honored to have you, ma'am.
I would now like to invite Dr. Vinita to extend a warm welcome to Major General Professor Atul Kotwal, SM, VSM, Executive Director of NHSRC. Under his exceptional leadership, the organization has made remarkable strides in the growth and success of various health programs. His expertise has been instrumental in advancing our initiatives in quality and patient safety. Since his tenure began, the Quality and Patient Safety Division has achieved ISQA accreditation for a certification body, and training sessions have become more streamlined, leading to an increase in their frequency. We are truly honored to benefit from his invaluable guidance and experience.
I would request my colleague, Dr. Deepika Gaur to warmly welcome Dr. Neha Garg, Director of NHM, Ministry of Health and Family Welfare, Government of India. Ma'am has constantly offered invaluable support in guiding the program activities and have been instrumental in coordinating with the Ministry of Health to ensure seamless execution. Her unwavering support for NHSRC initiatives has been crucial to their success. We extend our heartfelt welcome to you, ma'am.
I would request Dr. Amrita to please welcome Dr. J.N. Srivastav, Advisor, Quality and Patient Safety Division, NHSRC. Sir leads the Quality Initiative for the Ministry of Health and Family Welfare, Government of India, and is instrumental in successful implementation of various quality-related initiatives.
अब मैं मेजर जनरल प्रोफेसर अतुल कोतवाल एसएम वीएसएम एग्जीक्यूटिव डायरेक्टर एनएचएसआरसी से आग्रह करूंगी कि आप पेशेंट सेफ्टी के महत्व पर अपने विचार हमारे साथ साझा करें। ओवर टू यू सर।
Thank you. Good morning, everyone. Mrs. Radhana Patnaik, ASNMD NHM, Ministry of Health and Family Welfare, Government of India. Dr. Neha Garg, Director NHM. Dr. J.N. Srivastava, Advisor QPS. Mr. Harsh Mangla, Dr. Saroj, Dr. Ranjan from NHSRC, Dr. Hilde, Jan Jaktar from Academy of Hospital Administration, and Dr. Sangeeta, and all the other dignitaries in the audience. And the most importantly, all the representatives of the states who are here with us, who have traveled all the way from states to be part of this event today. And not only for today, I would like to place on record our gratitude for you all from the states being part of this quality movement, which is now, as we say, the sine qua non, the most essential thing if we have to improve the trust and faith of the patients of the entire community in the public health system. So a big thanks to you and gratitude to you, and all the best also for future endeavors, because our task is going to become more and more as such, if we say, because we have to certify so many facilities, and also to ensure that we sustain whatever we certify. And without certification also, at least the quality processes need to be put in place. Look at the inputs, the processes, the outputs and outcomes, and also the behavior, the antimicrobial resistance, AMR, all the other issues of quality. And that way your task is quite tough, but quite challenging, but again, at the same time, very, very rewarding. So I will not go into statistics, because you all are aware of that. And I will not go into the numbers of how many we have assessed till now. I think that also is well known to you. I would just like to highlight few of the key achievements of the Quality and Patient Safety Division, and which have been possible because of your support at the states, and also most importantly the guidance from the Ministry of Health under the direction of the ASNMD ma'am. And as mentioned by the hosts of this, by the Masters of Ceremonies here, since the time she's joined, there's a real impetus to the quality movement. We're getting the support, we're getting the direction. And that's why we went out of the way to first assess the district hospitals instead of states asking us to assess the district hospitals for certification. That's something unique which has never been done earlier. QPS team will be sharing with you subsequently the result of that assessment. And but very heartening to see that several states realize this, and they have promised us that yes, definitely they'll look at the gaps immediately and try to get these certified at the earliest. The other is this Sakushal, the safety and quality self-assessment tool of health facilities, with 4 major areas: the safe patient care processes, clinical risk management, safe care environment, and patient safety systems as such. So that assessment has been done by district hospitals. In technical sessions, again, the details will be shared with you. And that's also an important tool. And in fact, learning from this, we made the IPHS tool also, which is helping the states now to look at all these systems, also the standards, to that improve the entire health system. Because as we all know, quality is not in isolation. For quality improvement, we need to improve the entire health system in totality. So that's another very important initiative for self-assessment. Another this thing is that the WHO, we have been designated as WHO Collaborating Center for implementing patient safety programs. So that's another big achievement of either in the Quality and Patient Safety Division's cap and NHRC's cap, and also the Ministry of Health and Family Welfare as such, because we are now, looking forward to working with the CRO countries and also countries beyond that. And as Dr. Srivastava sir mentioned, that we were the first country to have the actual national patient safety implementation framework in place as such. The third is this, as to the title, as the theme of this year, improving diagnosis for patient safety. So that way, to improve the diagnostics, our HCT division is working incessantly along with all the other technical divisions as such, to work with the states, not only for the quality requirements for the diagnostics, but also to look at how the free diagnostic services initiative can be further strengthened, and all the diagnoses are available as per the level of care, and also the patient transport systems are there, the sample transport systems are there. So instead of patient moving from one facility to the another, is a sample which moves from the sub-center arm to up to district hospital level or CHC level, that the block public health unit into district public health labs which are coming up as such. So that will be the ease of living for the patients. And coupled with this is the QPS division also looks after this free drug services initiative. And these two are important components of the out-of-pocket expenditure. And as the national health accounts clearly shows, sharp drop in out-of-pocket expenditure. The 42% is because of drugs, and 11% is because of diagnostics. So that's why we are addressing about 50+% of the out-of-pocket expenditure. And these are the major initiatives, and improving the quality further will involve people more in coming to our health facilities. I think I'll save time because we look forward to the directions and inspiring thoughts of ASMD ma'am. So I'll stop here, but I must compliment and congratulate the QPS division for all the QPS quality and patient safety initiatives, and also their collaborations and the success they have achieved till now, and wishing all the best for the future endeavors. And thank you very much for coming over here from all the states and to all the dignitaries. Thank you.
Thank you so much, sir, for your kind words. With profound respect, I request Ms. Aradhna Patnaik, Additional Secretary and Mission Director, Ministry of Health and Family Welfare, Government of India, to deliver her address to our guests. Over to you, ma'am.
A very good morning to all of you. Dr. Kotwal, ED NHSRC, Dr. J.N. Srivastava, other dignitaries present here, representatives from the state, ladies and gentlemen. At the outset, I would like to congratulate the QPS division for organizing this function today on World Patient Safety Day. Basically, 17th September, if I am correct, is celebrated as World Patient Safety Day. But yesterday, I think there were lots of other programs. All of you are aware, 100 days of government was concluded on yesterday. So there were a lot of engagements, and all of us were busy in that. So we couldn't organize this conference yesterday. So today we are all present here to discuss on the issues on safety, patient safety, and quality issues that we find day in and day out in our public health facilities. I'm just reminded of a few incidents. Just I'll narrate one or two of them. Sometimes whenever, time and again we read in the newspapers some operation happening, and by mistake doctor leaving the scissors in the stomach of the patient or gloves in the stomach of the patient. Such incidents are really painful. When you hear it, and the first thing that comes to mind ki thank God mere saath aisa nahi hua. This could be avoided, and this can be done if we really work with quality, with precision. Another incident, all of you imagine you are in a plane flying from Delhi to New York, and the pilot forgets to check all the various checks and balances that he has been trained to check before flying the plane, and something happens and the plane crashes. So all are dead. This also could be avoided. So basically, anyone in any service has to work with precision, keeping in mind patient safety, keeping in mind the person you are serving, his or her safety. And I think all of you know that it's said the birth and death are in the hands of God. But I would add on to it, in the hands of God, and God's agents or God's messengers are doctors on earth. So on earth, for a normal person, for any person, any pregnant woman, any diseased person, any TB patient, any malaria patient, any cancer patient, it is the doctor. The patient looks towards the doctors with rays of hope. He and his family think that ye doctor sahab kuch to karamat kar lenge. Even if one knows that the patient is about to die, still that 1% hope is there कि डॉक्टर साहब कुछ तो मैजिक कर लेंगे कि हम जिंदा हो जाएंगे. So that is the faith, that is the trust that the doctor community need to build with the patients. And for that, the most important thing is patient safety. And for patient safety, what have you to do in your practice wherever you are working is ensuring the best of quality. So that's why our focus in the ministry at present, after I have joined, as previous people have said, I have always, this has always basically troubled me. Why are we not able to save patients when it is possible? There are certain things, 1 in million cases, where they say कि ये ईश्वर की इच्छा थी, where doctors tried their best but couldn't save. But there are most of the cases where through your sincerity and your alertness and your precision, you can save the patient. And that can be done if we have proper safety measures in the hospital. Infection control, infection management. Why can't this be avoided? Lot of patients are dying because of poor sanitation practices, poor hygiene conditions in the hospitals. Small hospitals, clinics. We hear even normal deaths also, in case of normal deaths also at times, due to improper management, deaths occur, either of the child or of the mother. So these can be avoided if we ensure that each of our facilities are quality certified. The NQOS, as Dr. Srivastav has rightly said, has many components which mainly focus at the background of, or the backdrop of everything is patient safety. Patient safety is prime. So for patient safety, what are the protocols to be followed in all the procedures, in all the processes? So that is why we are focusing in the Ministry of on NQOS certification of all the facilities. Very recently, we have, after the formation of the new government, we started virtual certification of health subcenters. That is the lowest rung of the health facilities. All of you, those from states, are aware, and the other also, all of you are aware. This is where it is the first point of contact for the village people, for the rural people, for the common masses. And if there also we have such practices which are poor, unhygienic, there's a lot of possibility that there would be high rate of infection amongst the patients who come there for their screening or for their checkup, be it pregnant women or TB patients or any other category of patients. So that starting from there and then till the last, that is our district hospitals. District hospitals, we had started NQOS certification from 2015 onwards. And in 2015, if I'm correct, nearly 10 facilities were NQOS certified. And today we are at almost 14,000, touching 14,000. And in the last few months, I would congratulate Dr. Srivastav and his entire team under the guidance of the ministry and the continuous follow-up of the ministry, as well as the QPS division with the states. The states have really done exceedingly well. We didn't expect such good numbers in such few months. I think till last year, hardly 4,000 facilities had been NQOS certified. And today we are at almost 14,000. And we are targeting reaching at least 50% by December 25, and then by December 26, 100% of facilities to be NQOS certified. And to ease down the process only, this for the sub-centers, because we have nearly 169,000 sub-centers in the country. So reaching out to each and every of the facilities, doing this process, which takes almost 2 to 3 days, and 2 to 3 people are engaged there, and quite a lot of funds are also required for doing the proper assessment. So we have shifted to virtual assessment. But a word of caution, we have continuously reiterate, and I have time and again written to the states also, virtual certification doesn't mean compromise on quality. This only the team which used to go, the external assessors who used to go, they would be staying here, and from here through virtual inspection, they would be giving the certification. But the state assessment team will be there, will do their assessment as they were doing, and also the documents and everything, proper checking would be done by the central team. So without any compromise on quality, certification of number of facilities can be done. But I'm also happy to see that many of the sub-centers are still going for physical certification also. This is an option given both for physical as well as virtual certification for the sub-centers. But for all the subsequent levels, PHCs, CHCs, district hospitals, physical certification is only mandatory. I would request the states, this, as Dr. Kotwal was saying, this is also, this time we have started for the first time. Earlier, you were applying, the states were applying, and then the central team would go. This time, it was decided that for district hospitals to start with, first doing the assessment ourselves to know where the state stands, where the facility stands, and then help the state to improve the system, the processes, the procedures in the facility so that it is NQOS certified. After NQOS certification, also you need to ensure that it is sustained. At times we see that after 3 years when the team goes for assessment, again reassessment, then many of the facilities fail to qualify. So you need to continuously maintain it. And second observation which I had was, after the states do the assessment, after almost 1 year, the national team goes there. So there also we have asked that now the states should be ready within 3, maximum within 6 months to get their assessment done by the national team, because you have already done the assessment from your state team. Time and again, I have also requested our team to basically train the state teams who do the assessment. And we recently had 4 regional conferences with all the states participating at various parts of the country. There also, most of the states, when we discussed, we had some brainstorming sessions on quality. Most of the states, they were requesting for proper training of their assessors. There, some of the state assessors are quite, they were trained maybe 3-4 years back, and then now they want a retraining to be, refresher course to be done. And even if after you have been trained, basically it also depends on, some see the facility and give 99.9, while the same facility is visited by a strict assessor and would give only 80. So that also needs to be rationalized. So the processes, if properly all the assessors are trained, then proper assessment can be done, and quality assessment is being done by the national team. But I think in certain states, the state teams are not able to assess properly, because of which when the national team reaches there, they are not able to give the certificate. So this has to be taken on priority. This is the first time we have also added this as a conditionality for fund release. So subsequent fund releases would be linked to NQOS certification, the progress made in NQOS certification. Adding to this NQOS certification, there's also one requirement which Government of India has recently come up with, that all our facilities should have should adhere to some basic standards. That is the IPHS. IPHS 2022 standards, all of you are aware that the guidelines were issued last year, trainings were conducted. This year, for the first time, we are doing assessment of the health facilities. There's a self-assessment tool. We have an IPHS dashboard, which was recently launched by Honorable Minister, Health Minister, on 28 June. And facilities can first assess themselves, see where they stand, and then wherever the gaps are there, in infrastructure or HR, drugs, diagnostics or services or governance, that additional funds would be provided to the states, because state representatives are present here. So all of you also need to know that we would be linking funds to your IPHS compliance also. More than 85,000 facilities have done the self-assessment. It's a good achievement, because we started just 4-5 months back, and we have kept the target by December. This year, we'll do 100% assessment of all the facilities. More than 2 lakh health facilities are there. So we're almost reaching 50%. 42% is what we have reached already. And more than 60% of the facilities have scored more than 50 marks. Our ultimate goal is to reach 80. 80 out of 100, so 80% compliant. But at present, this year, we are targeting at least all the health facilities should be at least 50% compliant. So this also is essential. Why I am mentioning these things? Because this is the core for achieving the quality. So first you have basic standards, then you reach quality, processes, focus on processes, which will then finally lead to the outcome of patient safety. So this entire process, that's why this year, from this year onwards, our focus, though focuses on all the programs under National Health Mission. You must be aware there are more than 30-40 programs. All of them have goals which we are trying to achieve, but at the core, at the base for all achievement of all the outcomes, our first focus is on quality. So this is where all of you need to work on, and Government of India is very serious about it, and we want to achieve the goal which we have kept for ourselves, but it will not be possible without all of your support. This time the theme on patient safety is improving diagnosis for patient safety. So again, under diagnosis, all of you are aware we have the free drug as well as free diagnostic service initiative started from 2015 onwards. In many of the states, we have in-house model. We also have PPP model. Some states have hybrid model. But here, during our visits, I have visited 14 states. During my visits, mostly I have observed that in many of the states, there some of the states I'll not name, where it is very well established. It is a hybrid model or it is an in-house model, very well established. There's a proper chain of sample transportation from the subcenter till the highest level if the IPHL is there. And also for drugs, also quite good mechanism of supply chain management. But most of the states we found that the approximately 60%, 50 to 60% of drugs and diagnostics are available. Our condition is 80% of the EDL, that is the essential drug list, should be available at all the facilities, sub-centers, PHC, CHC, sub-district hospital and district hospital. Same for diagnostics. We have the various numbers, how many to be available, how many types of tests to be done at sub-center level and subsequently till the district hospital. But in most of the facilities we find, and all of you know that if drugs and diagnostics are available, then out-of-pocket expenditure can be drastically reduced. Because after PMJ, we have the inpatient, 5 lakh assurances there for a patient to get treatment in any higher facility, be it a government hospital or a private empanel hospital. That is there, but only the operation or only the IPD is covered by the PMJ. For drugs and diagnostics in all our health facilities, government has provided free drugs and diagnostics. And if the drugs and diagnostics are not available, then it will result in out-of-pocket expenditure. So the 42% at present we have reached, we have come a long way from 69% to 42%, but still 40% of the out-of-pocket expenditure which is happening amongst the patients. Most of it is attributable, we can attribute it to the drugs and diagnostics. So this is one sector where we really need to focus on and ensure that as per the EDL, both drugs as well as diagnostics are available. For diagnostics, as Dr. Srivastava was saying, IPHL is the last mile, the ultimate public health laboratory at district level, which we have established. More than 100 odd IPHLs have already been established and are functional, but the supply, the continuum, the chain, that needs to be properly established from the subcenter to the CHC where the BPHU is being established, and then from BPHU to the IPHL. And for IPHL also, on 28 June, when we launched the virtual certification as well as the IPHS dashboard, the IPHL guidelines, the NCOS guidelines for IPHL was also launched that day. So that also now the trainings will happen. Some of the trainings have, I think, already started, the trainings. And after that, we would want that the states should make the IPHLs fully functional and adhere to the quality standards and get themselves also NCOS certified. So apart from our sub-centers till the district level, now we are targeting IPHL and then subsequently also BPHU. All these will be targeted for getting NCOS certified. So overall, my message to all of you is, please work on the gaps, the deficiencies that still we have come a long way. All of you have done a lot of good work. Lot of facilities are, I have visited facilities which are excellently performing, doesn't look like visiting a government facility. Very well trained professionals, very dedicated, beautiful system, in place, kept in place, cleanliness, perfect cleanliness kept, and proper procedures followed. And most of these facilities which I am talking of are, all of these facilities which I am talking of are all NCOS certified. And the best part which I heard from the people, the patients, as well as the professionals. The professionals said, I said, what is the difference between NCOS certified and before when you were not NCOS certified? They said the drastic difference is we ourselves feel very motivated that we are working in this hospital. And the second part is patients, the footfall has drastically increased. It has almost jumped to double, triple. And also trust of the patients. That is what they said, that earlier patients were reluctant to come and they were not feeling very comfortable. Now that trust has come, that confidence has come in the patient. So that is the basic difference. And same when speaking to patients, that is why they said that we are not going to the nearby facility because it is not NCOS certified. We are coming here because this is NCOS certified. So we know that all procedures will be properly followed, the protocol will be followed, and we will be taken care of. So this is the message we want, that each and every of our facility, the Government of India wants that each and every facility becomes NCOS certified and we give the best service that is possible. And the entire health professional, as I said, you are God on earth. So keep up to that. Thank you.
Thank you so much, ma'am, for sharing your valuable insights with us all today. Now I would request Ms. Aradhna Patnaik, ma'am, Additional Secretary and Mission Director, Ministry of Health and Family Welfare, Government of India, to please administer the Patient Safety Pledge with everyone present here and to the nationwide who have joined us with virtually.
शपथ पहले हिंदी व बाद में इंग्लिश में होगी। आप सभी से निवेदन है कि आप सब अपने स्थान पर खड़े होकर शपथ ग्रहण करें।
So, they don't have this? So I'll start, actually you have. मैं शपथ लेती हूँ कि मैं अपने स्वास्थ्य केंद्र, अपने समाज और राष्ट्र में रोगी सुरक्षा को प्रोत्साहित करने के लिए हर संभव प्रयास करूंगी, जिसमें उपचार के दौरान रोगी सुरक्षा के लिए निदान में सुधार करने के विषय पर विशेष ध्यान दिया जाएगा। मैं स्वास्थ्य सेवाओं को सुरक्षित बनाने हेतु महत्वपूर्ण भूमिका निभाने के लिए प्रतिबद्ध हूं, जिसके लिए मैं निम्न प्रयास करूंगी। रोगी के उपचार के समय होने वाली कमियों की पहचान करके उन्हें पूर्ण रूप से समाप्त करने हेतु प्रयासरत रहूंगी। रोगी सुरक्षा से संबंधित सभी विषयों पर स्वयं के ज्ञान को बढ़ाते हुए अपने कार्य कौशल में सुधार लाऊंगी। चिकित्सीय उपचार में सुधार के लिए रोगियों और उनके परिवार के सदस्यों को सक्रिय रूप से सशक्त और भागीदार बनाऊंगी। रोगी सुरक्षा के बारे में सामूहिक जागरूकता बढ़ाऊंगी। सामूहिक सहयोग के माध्यम से स्वास्थ्य सेवाओं में पारदर्शिता का समर्थन एवं प्रचार करूंगी। स्वास्थ्य सेवाएं प्रदान करने में हुई त्रुटियों से शिक्षा ग्रहण करके स्वयं में सुधार लाऊंगी। रोगी सुरक्षा को बढ़ावा देने के लिए अपने सहयोगियों द्वारा किए गए प्रयासों का समर्थन करूंगी। रोगी निदान के लिए उपलब्ध तकनीक, साधन तथा परीक्षण का उत्तोलन करूंगी। इंग्लिश I hereby pledge to undertake all actions for promotion of patient safety in my health facility, community and country, including the actions for improving diagnosis for patient safety. I commit to dedicate myself to make healthcare safer by supporting but not limited to following actions, namely identification and implementation of the ways to reduce errors in patient care, improving our skills and knowledge on all related subjects pertaining to patient safety, actively engaging and empowering patients and families as partners in improving their care, raising public awareness about patient safety, nurturing, supporting and promoting transparency in care through teamwork, learning from errors for safeguarding interest of patients, supporting my professional colleagues in their endeavor of promotion of cause of patient safety, leverage available technology, tools and tests to reach a diagnosis. Thank you.
Thank you so much, ma'am. I would request everyone to please take their seats. We would like to thank all our dignitaries for gracing this event with their presence. Your participation has added immense value to this event, and we are truly honored by your support. Thank you so much. We are happy to share with you that over 3,000 healthcare facilities have joined us through an online platform, and this World Patient Safety Day event is live on the NHSRC YouTube channel.
We are excited to inform you that we have organized a fun quiz stall that is Kaun Banega Patient Safety Champion right outside this hall at the same spot where registrations were conducted. We encourage everyone to participate in the quiz because you may win a prize if you get the right answer, so don't miss out. With this, now I would request one and all to please assemble at the amphitheater for a group photograph followed by a tea break. The tea is being served at the foyer area. I request my team members to please guide everyone towards the designated place for a group photograph. Requesting everyone to kindly assemble back by 11:30.
Invite you on to the
इसमें हाँ अभी पीछे वाला क्या आ जाएगा छोड़ आप पकड़ लीजिए।
बाद में देखा जाएगा है ना। ठीक है इस चीज का वो तो मीडिया ही है ना।
जो सर के साइड में अच्छा वो मैंने रख दी उनको कहाँ बैठाना है? पूर्वा माफी मैडम वन मोर चेयर नीड हमें सब एक चेयर चाहिए यार डन इसलिए यहाँ सर के प्रिंट आउट मैंने सर के कहाँ पे रखा है रंजीत जी
Second, Banani.
एक लास्ट बोतल का
ग्लास और बॉटल
I request everyone to please settle down.
I request everyone to please settle down so that we can start with our technical sessions. Requesting everyone to please settle down. Ladies and gentlemen, we hope you had a refreshing tea break. With the inaugural session now behind us, we are delighted to welcome you back for the technical sessions. This afternoon, we are privileged to hear from distinguished experts from across the country, each bringing their unique insight on the theme, improving diagnosis for patient safety in line with World Patient Safety Day. We encourage you to engage, learn, and enjoy the wealth of knowledge being shared. Let's make this session both informative and enjoyable.
We have displayed a walkthrough of activities held among different states during the Patient Safety Week and the glimpse of national event of World Patient Safety Day 2023, focusing on the theme Engaging Patients for Patient Safety near the quiz area. I would request you all to please have a look. I request all the speakers to please join us on the dais. Please welcome Dr. J.N. Srivastav, Advisor, Quality and Patient Safety Division, NHSRC.
Please welcome Air Commodore Dr. Ranjan Chaudhary, Vishisht Seva Medal, Advisor, Healthcare Technology Division, NHSRC. Please welcome Dr. Purva Mathur, Professor of Microbiology, Jai Prakash Narayan, Apex Trauma Center, AIMS, New Delhi.
Please welcome Dr. Juhi Chandra, Consultant Pathologist and Laboratory Quality Assurance Expert. Please welcome Major General Dr. Jagtar Singh, Vishisht Seva Medal, Director, Academy of Hospital Administration.
To begin with our technical seminar, we have first half of the session in line with World Patient Safety Day theme, that is improving diagnosis for patient safety. Sir and ma'am, total time allotted is 20 minutes. You will be intimated 5 minutes before with the buzzer. Okay.
Patient safety has evolved from reactive approaches to preventable errors towards a proactive system-based approach focused on creating safer healthcare environments. And to give an overview on improving diagnosis for patient safety, I would like to invite Dr. J.N. Srivastav, Advisor, Quality and Patient Safety Division, NHSRC, to please take up a session on this. Over to you, sir.
While my younger colleagues are setting up the presentation, okay, it has come. So I would request, in fact, all my colleagues, experts who are on dais, that they can ignore the buzzer I have told. As a host, I am having the overriding power. And you please feel free to engage with the participants, whatever they deem fit. So in the morning hours, we heard from Madam Aradhana Patnaik about talking about the different dimensions, different initiatives which the ministry has taken. But she brought out, in fact, the 2 or 3, I would say, the key messages for all of us. One is that the commitment at the highest level. That few of you may recall that we started this program in November 2013. And since then, a lot of ground has been covered. And now at this juncture, there is a commitment which ministry, even at the highest level, it is being realized that our common people, they deserve the best of the services, irrespective of their paying capacity. And the NQAS framework has been built around that. And the patient safety is one of the integral part. The second thing is the message which she conveyed is that there is no, in fact, the dearth of resources, which informally also ma'am was talking, particularly this message is for the states. We have got the representation from 22 states who are with us today. Most of them quality nodal officers, quality consultants. That ministry is fully committed and initially to fill the gaps in terms of the infrastructure, HR, drugs, diagnostics, equipment. The vehicle or the benchmark chosen is IPHS. But you also know with your quality background that under NQAS framework, few of you may recall that those 8 area of concerns, the input is a small component, though important one, and the total score allocated is around 10 to 12%, 15% at most. Largely it is the process-driven standards. And in NQAS, we normally focus on the process part. And since today we have assembled here to look that where do we stand in terms of the patient safety is concerned. It is not that we are talking for first time the patient safety. May recall that India is one of the countries where, in fact, the first country, if I recall correctly, the family planning program was launched. Subsequently, the immunization. And under both these standalone initiatives, the safety is inbuilt part. Like may recall, there is something known as AFI, adverse event following the immunization. And for family planning also, the famous case, Ramabai versus Union of India, when in 2003-4, when all the health secretaries, they were asked, they appeared before the Honorable Supreme Court, and all the health secretaries, they gave an affidavit that what they will be doing in their states for assuring the quality. And assuring means that this is a commitment which as a service provider or the government is making, that this is my benchmark where the services would be provided to all the people who visit the public health facilities. So these kinds of institutional framework is already in place. Similarly, we all know that under the patient safety, there are different dimensions. I just gave the 2 examples of the family planning, also gave the example of AFI. We all must have felt our challenge sometime when yourself, your family member, or somebody in the community who had gone to a hospital, contacted some infection, and came back with that problem. That is much part of the safety discourse which we are having. Similar thing stands true for the medication safety also. So the patient safety cuts across all the programs. The key message which I want to convey. Irrespective, whether it is in the pharmacy practices, lab services, which is the main focus area this time, or any, say, delivery, NCD care. So it cuts across everywhere. So when the patient comes to us, what does one look for? See, initially, when somebody is in the acute distress, acute say pain abdomen, or somebody has sustained injury, person looks for that, okay, there will be a place where I can go and my acute symptoms will be relieved. I mean, that is a concern of every individual who visits a health facility. whether in the middle of the night or during daytime. But for a chronic problem or the problem, subacute problem, there is a process flow. Process flow that patient enters, gets registered, goes and sees the doctor. And normally, over a period of time, all of you must have realized that the services or the clinical decision making is becoming much supported by the diagnostics. It is as simple as that, routinely asking for the hemogram or asking for certain, say, complex test. I will not go into those technical details or the molecular biology, etc., etc. We have got the subject matter sitting over here. But the point is that the diagnostics are being asked for. And then only the process flow, and even in the evaluation, when the person has been prescribed, even for the monitoring. Say, simple instance, we all know that our around 10%, 12%, 15% people are either diabetic or pre-diabetic. But still the monitoring takes place on account of, due to either fasting blood sugar, PP, but more importantly through the HbA1c, glycosylated hemoglobin. But if my reports are not reliable, is it not causing some harm? And in the morning time, when I was flagging the issue that when a patient comes to a particular facility, tertiary care facilities, it has become a concern also that routinely new sets of investigation are asked. I will not go into that certain unethical things which are also, but those form a very small minuscule. But largely, there is a problem of the trust factor, which the clinicians are not trusting. That is the one reason. And for monitoring of the patient, it becomes one of the thing, whether it is the, we all talk about the lifestyle diseases, either the lipid profile not being in order, or the diabetes patient, you name a problem. There are now the biological markers and so on and so forth. And the monitoring takes place due to that. So what we are looking. So when a clinician has come, basically patients and the service provider, they are looking at an explanation or the root cause that why a particular problem has happened. I still recall that when we were in the medical colleges, there was a focus on the clinical examination. I don't know how many of you doctor colleagues will remember that simple instance like murmur. There used to be 10, 12 criteria, and we all were busy in mugging up that, describing that. But it is no longer, the practices have changed. It has become the multi-doctor. It is no longer the standalone clinician taking a call. So, and the patients are also aware. They do their groundwork. So as a clinician, and every doctor wants to give an explanation to the patients that why a particular problem has happened, besides assuring himself also or herself also that am I on the correct path or not. And that is where the diagnostic play important role. We also know that everywhere, whether in the public system or in the non-government sector, gradually the importance of the diagnostic services have increased and increasing day by day. And we have to be accepting. It is not only that I'm talking about the traditional pathology, but radio diagnosis plays an important role, and there are newer technologies which are coming. In fact, the people, they have started talking about role of AI in arriving at the diagnostic. We have not yet reached to that level of maturity, which I am sure that within a year, 2 years, 3 years, that discourse will also come. Then the second important thing is timely. And in the timely, particularly, I would urge the colleagues coming from the states that we notice when we go as a part of NQAS assessment and otherwise also, that there are MOUs which the state governments have signed with the labs, but are the lab reports becoming timely, available in a timely way for the clinician or for the nurse to take a decision? That is a challenge. And the last being that effectively communicating, because the one point is that I said that importance of the diagnostics. Second point, I said that increasing role of technology. The third point is the communication. It is no longer that relationship which traditionally we have had, where the doctor was provided, you dish out a prescription, and the patient did not have any right. Nowadays, the trend is and the discourse is that the patients are supposed to be the co-producer of the care, which gets delivered. And in that context, it becomes important. Similarly, if we are to arrange, one thing is that any clinician would like to have a wish list, having all modern gadgetry, everything is available. But everywhere we need to see the resources. And as a hospital administrator, like we have got in the panel, General Jagtar Singh, old friend, that he has seen both the sides, corporate and that side. He would bear me out that resources becomes one of the critical factors to look at what the health system can afford. So timely, then what the health system can afford, and then evidence-based, in fact, the intervention which the clinician would like to undertake. So the availability of the investigation, the test becomes an overarching, which cuts across everything. Similarly, we also look in the diagnostic facilities, accuracy, timely availability of the, report for the clinician, for the nurses to monitor the patients, to take a decision. Efficiency, I've already spoken about. So the clinician-centered and the patient-centered. Both are the joint, and then timely communicating to the thing. So in our country, we have got the broadly two groups. One group is that those who can afford, you name a thing they will have. And we have got another group, then there are limitations. I still recall that in my medicine days, when somebody came with the space occupying lesion from the poor Tarai belt. And those days, in fact, CT scan was one of the very rare thing in a very specialized institutions. Those facilities were available. In the ideal scenario, the CT scan, that time MRI was not there, was the in thing, but we could not write because we knew that patient will go back and would not be able to afford. The well thought out call used to be taken, let's try out ATT. It could be tuberculoma. So the ideal practice demanded something else, but not so ideal practice. We had to try out, which will never withstand any scrutiny of the clinical scrutiny. So that's why I have said that one side is that missed opportunities due to health system issues. And the second side, we have that where there are no missed opportunities. But if you focus your attention on that red box, the challenges are on both the sides. Either my diagnosis is getting delayed, or there is a wrong diagnosis, or harm to the patients happen, or even there is a problem with the, harm somewhere, direct or indirect harm happening to the service providers also. It is whether the pathologist or it is a nurse or the lab technician. If my lab is not meeting those norms, say deciding norm is one part, but in the system, if those norms are not being met, simple instance, if those many air exchanges are not happening, somewhere the direct or indirect harm is happening. And that is where, in fact, we were going through in the IPHL, they have catered for, we have tried to build, again, there has to be some middle path. One is the ideal one is that what system can afford, and one is that in the middle path is that let's try to do something at this point of time, the preparedness of the system is there, and gradually it may change. Okay. So the short message is that diagnostic safety is the critical thing. It is critical for the service provider and critical for the recipient also from multiple angles. Whether if we want to have the better health outcomes, then timely and accurate availability of the investigation matters. And the the more interesting thing is that patient safety, in fact, I don't know how many of you were here in the last year or year before. Every year we have been talking. Patient safety talks about the preventable harm. See, there are two things. As a clinician, those of you coming with the clinical background will appreciate that certain amount of the adverse event will happen, even in the best of the institutions, whether it is the hospital-acquired infection or even the anaphylactic reaction taking place. But patient safety, the whole focus is that preventable harm, that word preventable. And the n number of studies have told us that only 4 to 5% the harms are unpreventable, remaining are preventable. And that shows us the quantum of harm which it causes. And this is the last bullet point is from one of the American studies. The source is there with me. I forgot to mention the source at the bottom. That 16% of harm is supposed to be with the preventable. In this slide, you can see that in the US system, these are the preventable harms which have been acknowledged. See, diagnostic errors about 1 million. 1 million means 10 lakhs, roughly. You can see that what would be the extent. We can just do some back of the envelope calculation that what would be the extent of harm happening in our country when we have got 1.42 billion people here with us. And our health systems are still not mature. And more surprising was that 2.5 lakhs pertain to the indoor patients. And with the deaths happening about, anybody's guess, but this study estimated about 40,000 to 80,000 annually people dying because of the diagnostic errors taking place. And there is a huge cost. I don't know, it sounds to me a bit mind-boggling, but 7.50 billion for a country like India, it appears to be a very huge figure, which they are acknowledging. These are the inefficiencies and the diagnostic errors which are causing. UK people, they are acknowledging about 60% of the harms because of the diagnostic errors. And the OECD countries, these are the 38 countries, they are acknowledging about 5% of the total health expenditure happening because of the diagnostic error. All these figures are available in the public domain. So you can take the help of Google Baba, and he will be more than happy to help you out with these figures. But the short point is that there is a problem, and there is a problem at every level. And globally also, the problem is still not being recognized. This is a compilation which WHO has produced. And you can see that horizontal bar in the red, where it talks about only about 46, 47% of the countries have started acknowledging the diagnostic safety. We have had enough discourse on the hospital-acquired infection. Medication safety we have discussed. Even the patient falls, we don't discuss in our country much, but in the other countries, it is one of the recognized problem. But for the diagnostic, still the system has not reached to that level. There are challenges. If I look at the holistically, one side in the peripheral system, there is an underuse, which I gave the example of suspected tuberculoma from my medicine days. And there is an overuse also. All of us are too aware which is happening. And the third category is misuse. Misuse in the sense, is the correct diagnostic or the investigations are prescribed for the indication, clinical indication or not. I'll quote an example. One of my personal friend, some time back, he was referred to a tertiary care hospital here in Delhi just for a simple procedure of colonoscopy. In my age group, around 65, having chronic constipation. He went for a simple investigation But the gastroenterologist sitting over there wrote all the possible investigations which could be carried out in Delhi. I will not name the facilities. Those of you who want to know with more detail during break, I will convey. This just happened about 3 weeks back. Simple case gets referred for the colonoscopy, and whole lot of investigations gets thing. So that is a simple instance of misuse, I would say personally. I don't know how many of you would agree or not. So basically there are 4, in fact, the broad groups. When I talk about diagnostic safety, delayed diagnosis, wrong diagnosis, misdiagnosis, or the diagnosis not communicated to the patients, or not communicated to the service provider. Not communicated to the service provider, like I will give an instance that under our NQAS framework, we have got one say checkpoint that whether the critical values are notified, and there is a system, there is a procedure where it gets communicated. Say late in the evening, a patient comes, an indoor patient, if the blood sugar has come in the range of 480 for 500, are we supposed to be waiting next day morning? I mean, during these 12 hours, substantial harm could have happened. So these are the smaller point which I'm trying to give you the glimpse, which are already inbuilt as a part of the NQAS framework. That communication becomes important. These are the 2-3 cases which I picked up while yesterday browsing through the sources given at the bottom, which you can go through. In this particular instance, this young man, 36 years old, having chronic backache with other related stuff, have been repeatedly visiting his primary healthcare facilities and no relief in the symptom. Comes back, talks to his mother, mother fixes up another appointment, and after say about 12 months to 14 months found to be grade 4 CA. These are the publicly documented thing. Website is given. Those of you who are interested, there are about 38 to 40 odd cases which are mentioned, which are publicly reported. Unfortunately, in our country, we don't have. And found to be the grade 4 carcinoma, passed away. So this issue, this case flags the issue of the importance of ordering an investigation, timely investigation. Another instance, this gentleman, hospital, in the foreign countries, it is all institutional delivery, took place. The short point is that the baby is having kernicterus, neonatal jaundice, bilirubin in the range of 34.6 to be precise. In the initial 3 instances, nobody asked for the bilirubin. No one. And then later on when it was tested, I don't know, but that becomes a clinical decision challenging, that only the treatment started was phototherapy. Without doing anything, ultimately, this person developed brain damage, irreversible. Frightening. My last case is this lady, having say fibrocystic disease, going regularly for the follow-up. She and her treating doctor notices that a cyst has enlarged. FNAC, fine initial aspirational cytology, ordered for, done. The report comes insufficient tissue or insufficient sample, whatever is written. Nobody bothers to look on the page 2, where it talks about inadequate sample with the last but one line, where it talks about inadequate sample with metaplasia and recommended abnormal test. मतलब पहला पेज देख लिया, उसके बाद जरूरत खत्म हो गई. So, that is a challenge in the subsequent I have flagged. With the gradual specialization, with the due respect to my super specialist colleagues, at times there are certain reports which are glaring, mentioning that okay, this could be the another thing which needs to be investigated, needs to be evaluated, probable thing. Like common investigation asked for is the ultrasound whole abdomen. If the gastroenterologist has asked for, with due respect, he will just look at the GE and maximum hepatobiliary system. And if there is anything, any suspected thing mentioned, very often, those are the gradually exceptions only, very often no actions get taken, or even the patient's worst thing is that, action taken says that fine, if the patient gets referred to that particular specialty, but nothing communicated to the patient. आपकी रिपोर्ट ठीक है, चले जाइए. So these are the harms. In India, as usual, we have the multiple challenges. So to conclude, do we know enough? Where is my data coming out for a decision to be made? We have many, say, point of care diagnostics. They are good. They are doing a lot of good. But what are the interventions for me to bring about the changes in the health system? That is a challenge. And what are the strategies? We would like to hear from all of you either today or some other time when we meet, formally or informally, that where we can engage with the Ministry of Health and Family Welfare. They are very supportive, but we need to be working that, okay, this should be the right roadmap for this thing. So the diagnostic services touches upon many dimensions, starting from the availability of a particular test, trust factor, then the correct diagnostics, correct investigations gets ordered, reports which becomes available. Then there is a holistic interpretation of that report which takes place. And so we need to be talking, we need to be covering. Today, experts will be talking about certain dimensions, but as a program officers, particularly those of you who have come from the states, please look at the system holistically, and let's not work on the band-aid approach, but look on the system approach. And I'm sure that with your support, with your commitment, which I can see, we'll be able to do it. Thank you very much.
Thank you so much, sir, for a wonderful session. Diagnostic errors have been reported to occur about 5% of adults every year, which can potentially cause severe damage. To shed light on this issue, we have with us today Air Commodore Dr. Ranjan Kumar Chaudhary, VSM, Advisor, Healthcare Technology Division, NHSRC. Sir is a healthcare specialist and a management expert skilled in healthcare consulting, strategic planning, medical equipment procurement, supply chain management, healthcare technology, and hospital operation. I would like to invite you, sir, to share your valuable thoughts on the diagnostic errors, the next frontiers of patient safety.
Thank you. So at the very first outset, I must thank ED NHSRC and Dr. Jain Srivastava, who gave me this opportunity to share my ideas, and the august audience. You're all learned, qualified. So today, this topic, it's hold relevance and importance to each one of us who are present here in this. And then we have to communicate it to the further down below. The topic says, the diagnostic errors. We all have been talking since morning. There are many scope of diagnostic errors, right from when a patient comes for the first interaction with a doctor until he gets a treatment. So I'll just share my thoughts and take you around. Most of the inputs and this thing are from the WHO guidelines. So to start with, this is known to everybody of us, the 9 moments of patient safety. If I can reiterate, I'll say the medication safety, the surgical safety, infection control, diagnostic accuracy, for which we were discussing today. We saw that, red band also in the diagnostic at around 49%, around like that. Patient identification, very important. Communication, very important. Patient falls, preventing falls, pressure ulcers, and the blood transfusion safety. These are the 9 moments of patient safety. So what is all about the diagnostic errors? A diagnostic error emerges when a diagnosis is missed, inappropriately delayed, or is wrong, which Dr. Jain Srivastava very nicely, elaborately and mentioned that. There may be many overlaps in this classification. Now, this diagnosis often occur over time rather than at one point in time, including the initial assessment, performing and interpreting diagnostic test, follow-up and tracking of diagnostic information, referral-related communication and coordination, and patient behavior, adherence, and engagement. You see, there are multiple and variety of factors right from the patient first interaction we go through. Now, diagnostic errors can occur at each of these points. Now, diagnosis is a high-risk area for errors in primary care. The primary care providers are faced with potential difficult clinical presentation as they have limited experience with uncommon diseases and varying access to diagnostic tests. I do remember when I was a young doctor and when a patient used to come to me, just like a fever is come. So the first idea is to find out why they have a fever or something. So we give some medicines, we give paracetamol and all, order some test. After that, the most important is after 4 or 5 days, when the patient is not getting the relief, then we refer them to the higher. But then we lose the contact. We just lose the follow-up. So I used to keep a small diary, and when the patient was referred after 2-3 days, used to ring up and find out what is the diagnosis, are you happy, are you got treated, and then the response and the feedback what I was getting, that was my learning experience. We all have to learn by follow up and from our mistakes. That's the key message which we are sadly lacking right now. In the primary healthcare setup, there are limited knowledge, limited resources, limited diagnostic test. But then when we are following up, and that's what is the continuum of care, the patient should come back, you should hear about, and then you make a note what all diagnostic errors has been done or something like that. So that is a very good strategy which I assure with such quality conscious people around here may communicate down below. The follow up is very important. So the burden was shown here. I just gave one of the picture here right now. In a country, we don't have any repository like the National Health Resource Repository, NHRR, with the CHBI. They are trying to make a repository, but there is nothing. I scanned the internet and all to have some case studies in India context having these diagnostic errors, but unfortunately I didn't get them. It's high time that we start building a repository to understand where we are committing mistakes. Is it at the prescribing mistakes? Is it at the diagnostic error mistake? As I go by, I'll say the maximum mistakes we do is the judgmental, is the cognitive errors. I'll say. So delay, as mentioned, misdiagnosis or a delay in diagnosis equally are attributing to the diagnostic error. The MVPI thankfully launched, this program, National Metro Vigilance Program. This has come to some standard where the adverse events or effects on a patient with the application of a medical device are being reported. And every quarterly, there is a expert partners meeting where these adverse events are discussed, which I'll show you around. So firstly, the terms we should be very familiar is, the near miss event. This could have caused damage, but didn't. The situation like fungus in an IV bottle, if you detect it just in time and you discard that. So this will be an example, sudden equipment failure, but it was not applied to the patient and you saved the patient. So they are near miss. This should be reported. The adverse event is already, caused damage that was not serious and lasting. The patient survived somehow, like medication error or a slip or fall from the patient, bed causing injury. And sentinel event is caused death or major enduring loss of function lasting at least 2 weeks. Wrong detection of the cancer, wrong diagnosis, I'll say, the wrong site, wrong patient, wrong surgery. These all events will come in the sentinel event. The common diagnostic errors are, as mentioned earlier, the delayed diagnosis, failure to diagnose an unrelated disease, failure to diagnose related diseases, misdiagnosis, failure to recognize the complications. So these are usually the common diagnostic errors we face. So when a doctor eventually makes the correct diagnosis, but it takes a significant period of time. For example, UTI patient comes with a urine infection. What we do is first give some antipyretic and get a urine for the culture for the next 3-4 days. And then we give a empirical treatment, and that also patient doesn't, get all right. After 7 days, then we try out, let's go for a higher antibiotic, and then we refer. So we already damaged. We gave a 2 antibiotics, and after that refer to a higher institution for thing. So here the time delay has caused, the diagnostic error for the patient. Patient, if you would have been, referred earlier, say after 3 days along with the report, I think it would have been a better situation. So like this, many situations happen which we don't record. So even in the cancers also, you come with many symptoms which seems very innocuous, but we keep on treating, and after some time it comes out that we miss the diagnosis totally. It's something else, like Dr. Jain sir said. For a heart attack, a very sentinel event, patient comes with gastritis symptom, and we keep treating of gastritis and something discomfort. If we don't have this clinical acumen to go for a might be a heart attack, we can miss a very serious case. So these are the cases where we have. And what are the factors which I was mentioning? All aspects of the diagnostic process are vulnerable to error. Most important, 71.2% is the cognitive error, is the judgmental errors. Failure to synthesize the available evidence correctly, or failure to use the physical examination or the clinical signs and symptoms to interpret it correctly and appropriately. This is the most common in a primary healthcare setting. So I will narrate one history. Like one of my friend, he had come, and he, while playing cricket, he got a small injury by a cricket ball. So he was an aviator. So he came to me. I said, "Don't worry, just take a ball and clutch it. You will be getting all right with that." But then he took leave and came to Delhi, and he wanted to fly again as quickly as possible. Went to a plastic surgeon, spent some money, and did some procedure, and later came with a crooked finger like this. So there are a number of cases, but the problem is the trust, the patient and doctor trust is very important. We have to develop both ways. Here, as a doctor, just I prescribe, and the patient will take it. There is no guarantee. You have to build that trust in the patient, so that the patient, after the good communication, understand why it is important to take the right medicine and the right way. That's very important. So after that, there are system flaws, the problems with the communication and coordination of care, as I mentioned, availability of the correct medical record. Many a times in the hospitals, you must have heard of wrong site, wrong surgery. Even ASMD ma'am was saying at times when you operate, you leave, some sponge, that seizures and all that. So these things are because the procedures are not followed correctly. So that is how the MHF and W and everybody has come out with STGs, standard treatment guidelines. And these are to be revised and followed by every health setup. That's very important that the doctor sitting there know about the STG, and we form everywhere the same STG is followed. Similarly, for the diagnostic, tests, if you go and do a test at one lab and the another test, you will not get an exactly matching result. Why? Because in the country, we don't have that inter-lab comparison efforts done. We are promoting that. We are saying we must enroll into EQUAS, external quality assurance scheme, and you should have inter-lab comparison so that at least a reasonable parity is maintained. So this is very important, wherein we do these diagnostic tests, the pathologic test. Accuracy and the timely report will only increase the reliability and the trust between the patient and the consumer, basically the patient and the health facility. Then we have this process breakdown. A study was undertaken in a developed country, finds that patient-doctor clinical encounter breaks down like inadequate history taking. This we were taught when we were young that spend maximum time in history taking. Now with so much of rush in OPD, doctors cannot give more than 5 minutes, I think. So the history taking is very important to elicit, the symptoms and go in the right track. Missing signs and symptoms, asking diagnostic tests for further workup, referral problems is all listed there. And the most important is the lack of communication. We don't communicate. And with the more gizmos coming and with that IT tool and enable, we don't even look at the patient. We start filling up our IT. So a touch between the patient and to listen to the patient is the, Hutchinson's clinical manual. I remember it says the first chapter says that only. So we have to be connected with the patient to know and understand this thing. So these are the few areas, like a patient side access to high quality treatment. They always, expect that, okay, I'll get a high quality treatment. But the possible issues which are contributing to other, maybe due to limited access, the person. Now the quality is not defined actually the patient perspective or the doctor perspective. That's why I was saying that there should be a standard checklist, standard treatment guideline. If somebody is following that, that should be a measure or a standard for saying that yes, the quality diagnosis and treatment is being given. Similarly, other things are given, all other factors, availability of healthcare profession at the place. Many of places we don't have adequate manpower, HR. That's one of the very important thing. So everything is done in hurried. Teamwork is important. Availability of diagnostic test at each level of healthcare. That's how the NEDL, National Essential Diagnostic List, has been formed. These are the basic tests. After that, please refer. Don't hold on the patient. If you're not understanding with the diagnostic test result, refer to the higher institution. Communication and the care coordination, the follow-up, very important. This is again the same, the culture, what somebody saying, ki a culture of reporting should be there. Here we try to suppress. Like I remember in hospitals, you are supposed to have death reviews, mortality, audits, but hardly any hospital do that, I think. I started off, many physicians, they shy away. They don't want to attend all that. But until and unless you review a case, you identify where we committed mistake, then it will be repeated again. So the culture of, critically seeing any event and analyzing and finding the gaps and taking learnings from that is very important. That culture has to be developed in our hospitals. These are the few areas, like in infection, viral infection, still we prescribe antibiotics and often misdiagnosed. First we think give an antibiotic. Malaria again presents with different varieties and all. TB, you all know these all incidents I have already discussed now. Pediatric is another group, very common group, misdiagnosed. If you can't put a sthetho, the pneumonia, if you can't detect in time, it's, very, very, the child, you may lose the child. Even gastroenteritis and all the very common things, where we miss out. This already, I think Dr. Jain Srivastava spoke about at length, the missed opportunities and all. So what is important is that B and C, the harm from delayed or the wrong treatment. This we should prevent. That's very important. Now, little bit about the material vigilance. Why I kept it intentionally was there is a good audience to show that we have a program called as Material Vigilance Program of India. On 6 July 2015, it was launched. And Indian Pharmacopoeia Commission, IPC at Ghaziabad, they are the coordinating and the nodal agency. They are the National Coordination Center, and Sri Chitra Tirunal Institute of Medical Science and Technology. They function as the National Collaborating Center. And we are also a technical partner to this committee. So these are the categories of the medical device, and most important is to remember the class C and the class D. They are moderate, high risk and high risk medical devices. The examples are given there. Now I'll just show you that these are the amount of, medical device adverse events are being reported, and which we sit in a partner meeting. Imagine we have a spinal implant given and the implant breaks. They are serious. So what we do there is there are an expert committee who tries to find out, is it a device related error or it is a procedural or a, doctors, physicians or surgeons procedural error. So after that, a decision is taken. Similarly, there are n number of things which I am showing you here. So what is more important after that is that any device or any POCT, when it is introduced as an intervention in our healthcare, we should do a post-market surveillance or post-utility. Once it's being used, the feedbacks are important. If it is performing well, or if it is not accepted, or it's causing some adverse event, it should be reported by everybody. Then only there are legal system where you can recall that item or ban that item. So in this slide, the periodic safety update report, which the manufacturer is supposed to provide, to get the post-market surveillance data, is never done. So there are gaps in the system, which I think we should strengthen it by making the people aware that these feedbacks really do matter to us. These are the reporting of this channel. It's in NHRC website. We have given all the resource material, so you all can log into it and can disseminate to down below for reporting any adverse event happening in the health facility. So what are the options with the regulatory authority? Either they can notify the manufacturer to take appropriate action, product correction, sales restriction, market withdrawal, audit inspection, sample testing, issue a public announcement, safety alert or recall, and inform targeted healthcare providers, escalate the safety monitoring. These are the actions available with CDSCO, our regulatory agency. So what all interventions we can do now to reduce this burden of diagnostic error? So training and skilling, most important. Training, capacity building. It's like a good pilot. When you touch down, you'll never come to know your aircraft has landed. Similarly, a good doctor with a good clinical acumen will solve majority of your problems at the first visit or a maximum second visit. So it's important that skill-based, training, learning, and on-job training is very important. The patient has to be empowered. You have to have a good relationship with the patient and encourage the patient to speak up and tell what has happened after your intervention or your medicines. Strengthening the health systems, robust referral and follow-up mechanism at the primary healthcare center. This is where is the important. We must see what all gaps we are having in our primary healthcare in a PHC level or at a sub-center level. So these gaps, though they are hidden, nobody announces it. If I commit a mistake, I am the last person to own it up. So, but the systems and processes like NQA sees that way, the process, they are the actually, if somebody follows those processes in the NQA's checklist, there are less chances of making error. That's very important message. And again, the use of IT and EMR now, our health minister has also advocated that we should have good EMR system, both public and private in the country. The NHA is already working on it to have ABDM compliant EHR. So this all should be, done up, and IT should be there, a portal where we can, have a registry of all such near miss, adverse events, or some sentinel events recorded. It is high time that we should have this, and we should analyze to find what are the corrections we can do. So these are the few of the suggestions given. Ki if we have access to the diagnostics, there are conditions where a CT scan, you all know, is ordered just because it is in a PEP mode. When we visit in the field and visits, we find the same person has undergone 3-4 times CT from the abdomen, sometime there. How much of radiation they are getting? There are 6 times more than the X-ray. So a prescription audit, as a quality managers and all, we must ask for prescription audit. Ki why this person has been advised 3-4 CTs, the justification has to be there. So these all are very important. Like Jain sir has said, ki a person goes and whole list of tests has been done just for a colonoscope, simple, procedure. So we have to encourage a culture of self-reporting of diagnostic errors, near miss events, and the adverse events. So I told that training and capacity building is prime most important, patient communication and coordination, and establish a work system and culture that supports the diagnostic process, and develop a reporting environment system and create awareness. And patient should be able to use the Mera Hospital application, which we already have strengthened this. I think the new guidelines have come. This has been revised also. We must encourage every patient to provide their feedback on Mera Hospital. And I'll end with this again, 9 patient safety solutions, started with the 9 patient safety moments. So you all must encourage that the 9 patient safety solution, which has been advocated since long, at least we keep them in the place. The NQAS framework has all these safeguards inbuilt in it. So this is what, and thank you very much for the patient hearing. Thank you.
Thank you for the outstanding session, sir. Conformance to the quality standards is of prime importance when it comes to patient safety in public health facilities. To elucidate on this topic, we have with us today Dr. Purva Mathur, Professor of Microbiology, Jai Prakash Narayan, Apex Trauma Center, AIIMS, New Delhi. Her expertise lies in the area of surveillance of the hospital-acquired infections, infection control and microbial resistance. I would request ma'am to please elucidate us on key performance indicators for labs, dashboards for improving accuracy and efficiency. Over to you, ma'am.
Good afternoon and thank you so much. I wish to thank NHSRC, especially Dr. J.N. Srivastava sir for giving this opportunity. So, quality is something so important in our daily lives, We crave for quality food, quality products, quality television, quality clothes. But when it comes to sick patients visiting hospitals, we fail to accept the fact that they also deserve quality care and quality diagnostics. And that is our duty. As sir said, that whether it's the poorest of poor or the richest of rich, everyone deserves a quality diagnostic or a quality treatment facility. So, just to have a corollary, we have so many branded clothing, outlets and chains, and we get the same kind of dress from wherever we buy, right? We can buy it from Delhi or from Mumbai. We get the same quality, the same sizes. Does it happen with a laboratory report that if you give a blood sample, you get the same report from different labs? More often, the answer is no. We don't ensure that the quality of report that is generated from our lab can be reciprocated. And that is why, we must have key indicators which justify that our lab is giving quality reports. So, in case of laboratories also, our aim should be that wherever the patient gives his sample, the same parameters or the same indicators or the same report is generated, right? And that is why it's very important. Many of you are from the state levels, that you must enroll in some kind of external quality assurance system, and that helps because you will know that whether you are in the range, which is a standard range provided by the ECPAS providers, the PT panels, and you will understand where your lab stands, and it will help you improve in generating quality reports. So we'll briefly understand what we understand by key performance indicators, which are known as KPIs. What are the attributes of an ideal KPI? And what are the factors when we are working in a lab that affects the final generation of reports? See, if you have gone through the NABL process, you will understand that a lot of emphasis is now in the NABL 2022 modification. A lot of emphasis is now given on risks. And risk can be to patients and to the healthcare workers also who work in the lab. So a faulty report is a risk to the patient, because if you are giving a wrong report, the wrong diagnosis will be made and the wrong treatment will be given, and that's why it's a risk to the patient. So those risk factors can occur in the pre-analytical phase, in the analytical phase, and post-analytical phase. And then I'll briefly touch upon what are the key performance indicators that we use in our laboratories and how establishing KPIs can enhance the diagnostic accuracy and efficiency. So what do we understand by a quality indicator or a key performance indicator? So these KPIs are evidence-based and data-driven measures that provide the healthcare makers with decision-making tools to provide access to their data, assess their data, highlight potential quality concerns, because that is something day in and day out we must do when we are working in the lab, that we must discuss with our team that what are the areas of potential concern, what are the areas where a report may be faulty or a wrong report may have been delivered to the patient. Then identify areas that need further study and investigation and track the changes over time. So if you are doing a quality improvement initiative, supposing you have a machine which is giving errors and you call the vendor and you make changes, and then you have to track the reports over the next 1 month to see whether the improvement has happened at the level of report generation. So what are the attributes of an ideal key performance indicator? It should be objective, measurable and quantifiable. You cannot have vague KPIs, that I can't have a KPI like I want to generate a good quality report, because that's not a measurable indicator that any lab technician can measure. Anybody who is working in the lab should be able to measure and quantify that quality indicator or KPI. It should be actionable, because supposing your performance indicator, your performance is below the standard that you have put, the threshold that you have established for your lab, you must be able to act on that information. So all KPIs that you establish in your lab should be actionable. They should be easy to use. So it's not that you have a quality manager in that lab and only the quality manager can act on that. Everybody who is working in the lab should be able to use that KPI to make run charts and act upon that. It should be priority based, because there are certain quality indicators which are extremely important. Srivastav sir said that a very high sugar level at midnight, if you are not conveying as a critical alert, it's a very, very critical area. It's a very priority driven area, and it should be a KPI in your lab whether you are communicating those critical alerts. Completeness, so it should be comprehensive and include all areas that need analysis, means you should have quality indicators for the pre-analytical phase, the analytical phase, and the post-analytical phase, and there should not be an overlap. So what are the factors that affect the pre-analytical, analytical, and post-analytical phase? We found that most of the errors in the final generation of the report occur during the pre-analytical phase. And all of you are working in the laboratory sector. So pre-analytical means from the time the order for a test is generated by a clinician, to sample collection, to its transport, to its reception in the lab, to registration, and then finally when it goes to the processing areas. So what are the factors? A doctor gives a test request, the patient is not prepared properly. If you have to take a blood sample, whether you have taken care of the sterility, whether you have using the proper collection technique. So you have to inform the patient, guide the patient. If it's like a urine sample, how to take the sample, whether you have filled the test form correctly or not. Most often it's like, for urine culture, they'll just write UC. I've seen so many times UC. We have done it in and out. So I'll just give you an example. I work at AIMS Trauma Center, and sometimes I get many samples from the main hospital, and I found that at the top of the form, it's either written in the requisition, it's UC, which is urine culture, and the top I would often find PML written, and I would think that there's something which is happening. A lot of patients are getting PML, and I thought it's a very grave diagnosis, something like AML and CML. And when I got back to the resident, they said it's an acronym for Purva Mathur Lab. So it's like that. I thought, what is happening? Everyone is having PML. So that is the kind of forms that accuracy of filling the form. Then accurate patient identification, monitoring how specimen is collected and how it is transported. What are the factors that affect the analytical phase? When you are working in the lab, you have laboratory technicians. It's very important that they are trained. You have internal quality controls. It's very important that you go for NABL. So our lab just received the NABL 2022, and initially we thought that for government hospitals, why is it important? Government hospitals are not answerable. That's your normal thought. But because of our director, sir, and the push from the government of India, and we realized that acquiring NABL is so important, because you improve so much. You understand why quality is important, why internal quality controls are so important. So analytical phase, you must have good quality control, good instrumentations, facility for retesting, reporting accuracy, interpretation. You have something like a resistant bug, you have an MIC value, you must be able to guide the clinician that which antibiotic to give. Or if some liver function parameters is deranged, do you need to get it retested? Was it a machine error? What do the clinicians need to do? So it's not that we should not work in silos, isolation, that okay, I have given the report, now the clinician will rack his head over that. You have to guide the clinician for proper diagnosis and treatment. So guidance to treating doctor is very important. And in the post analytical phase, what are the factors that may impinge on, the key to diagnosis is how do you record and release the result, So um, uh, again, in many hospitals you have register based system, then you have systems which are integrated with the machines where it is easy that everything is exported to the clinical areas, but where there is a lot of transcription, you do have transcriptional errors, and that is why one of the KPIs should be how many transcriptional errors do you have, whether you are actually writing whatever the doctor has written, whether it is properly transcribed, what is the format of the report, whether it is written or online, whether there is patient feedback, patient and healthcare worker or the doctor's feedback. So there should be some mechanism to get feedbacks, and turnaround time. It's very important. You have ordered a hemoglobin test, you can't sit on the report for 2 days. So establishing turnaround times for each test that you are doing is extremely important. It's a KPI when you go for NABL, and it should be a quality indicator in every lab where you are thinking about establishing quality indicators. So turnaround time is something, if you actually breach your turnaround time, that is the time you need to really sit with your team and understand the reasons and do root cause analysis. So for pre-analytical phase, as I said, it's the most important source of laboratory errors, and therefore KPIs in this phase are necessary to keep these errors in check. Like how many samples came in a wrong container or in a leaky container or had improper forms. That's a key KPI because you have to involve the clinicians and make them a part of diagnostic stewardship. They have to be a part of the report that is generated, and a very important part because they are the ones who are sending samples, filling the forms. And so a key KPI is how many samples were not received in the proper conditions. So all the factors, sample collection, improper form, everything can be a reason for sample rejection. So it's up to you to establish that what is the threshold that I will reject this sample. There are some precious samples like an intra biopsy sample which you cannot reject because it's a very precious sample, and that is where you have to compromise. So KPIs should be established based on what is the importance and the preciousness of the sample also. So a sample rejection criteria with adequate documentation and informed reasons must be made, and the rejection should be informed to the clinician. If there are registration errors by the receptionist or staff, it's very important again to document. So at the end of every day, the quality manager must document how many samples were rejected, and then at a definite frequency, you must do root cause analysis of why your sample rejection is above a threshold. So one has to take actions on all pre-analytical KPIs, informing the clinical areas, because that is one step where the clinical areas are involved. They are sending the sample. So pre-analytical KPIs or the errors, or if you're shooting a threshold, must be informed to the clinicians, and on how to improve the performance, how these KPIs affect the patient reports, how they are ultimately a risk to the patients and the outcomes, and how do you mitigate the risk. During the analytical phase, our commitment should be to maintain internal quality control, managing equipment breakdown, conducting actual and accurate sample testing, which is very important. Your key job as a laboratory person is to do accurate testing, because the more accurate your machines and your human interpretation is, the more accurate your report will be. So these factors serve as key indicators, and vigilance in this phase is very vital. So you must record how many times your quality control has failed, how many times the test reports were out of range, how many times the equipment failed or the reagent fails or the equipment stopped midway, and what did you actually do for that? It's very important. So during the analytical phase, you report on some critical errors. There are critical errors in hematology, biochemistry, and microbiology, and you must establish your own critical errors. So whenever you're going for NABL, this is one of the major factor about what are your critical errors. Are you recording those critical errors, and is there somebody who is reporting back these critical errors through phone? And then you have to record that who was communicated, what was the name, And you have to give recall back whether they've understood your critical alert or not. So in microbiology, for example, a gram stain finding from cerebrospinal fluid or pleural fluid, or if there's a blood culture which has flagged positive and you do a gram stain, you have to immediately inform the clinician, because you cannot wait for 2 days for the sensitivity report to come. By that time, the patient might have passed on. So it's very important that these critical errors are communicated to. So one more example I'll tell you from my lab only. There was a blood culture which flagged positive, and on gram stain there were budding yeast cells. Now budding yeast cells are in short called BYC. We all call BYC grown. So it was a critical alert, and it was communicated to the ICU, and they communicated that BYC has grown. Now the nurse who took the phone, and then I got panicky call that there is a patient who is seropositive, and we got a phone and previous reports were negative. And so I said, which report? He said, there was a phone call, it said hepatitis B and C positive. So the nurse who took the phone, she understood that it was B and C positive, hepatitis B and hepatitis C. So that's why, critical alert, it should not be in a full form. Like you say BYC positive and they understand BNC positive. So critical alerts are very important and you must document it. So lab is responsible for informing critical alerts, and if it is not done, then one must do root cause analysis and corrective action. In the post-analytical phase, the correct result entry and report release, transcriptional errors is very important, and any transcriptional error calls for a root cause analysis, that why the report was transcribed correctly. And then turnaround times, extremely important key indicator, KPI, which is the time from the sample collection until the report is released. The TAT should be on alert in all labs so that the correct report reaches the correct patient at a proper time. So everyone in the lab should be aware of the TAT, which is there for a particular test, which will vary from a hemogram to a chemistry to a culture. And change in TAT is a definite KPI and must be adhered to. If there's any deviation in TAT, it is an area where lab needs to do corrective action. Some high value labs also use dashboards to check that the sample is deviating from their TAT. And it is mandatory that all samples should have their TAT reported. Turnaround time actually reflects the commitment of labs to deliver timely reports. So what are a few examples of KPI in laboratory? So this is a dashboard that we use, that for our laboratory, in the pre-analytical indicators, we have syntax error during patient registration, number of venipuncture failures, number of sample rejection, and number of times samples are marked urgent but they reach late. Analytical phase, how many times the test is rerun, alert values are not informed, that is critical alert, equipment failures, parameters with IQC outside the percentage CV. And post-analytical reports not delivered on time, which is increased TAT, reporting errors, number of complaints received from clinicians, and number of complaints received from patients or attendants. So this is also a very important key indicator. So what are the KPIs which we are using in our microbiology lab? It is the rejection rate, how many samples are rejected, registration error rate. In the analytical phase, how many blood samples were contaminated, which indicates that sampling error is there. And post-analytical, how many transcriptional errors, critical alert communication rate, and report error rate. So why we have kept blood contamination as a rate, as a KPI for analytical indicator? Because it conforms to the NHSN criteria for contamination, and it gives us an opportunity to train the clinicians on how proper sampling is important for diagnostic stewardship. So this is just a dashboard that we use. This is from our own SOP, how we actually calculate the rejection rate, like how many number of samples were rejected divided by total number of received into 100. Registration error, what is the rate of all sample contamination. Blood culture contamination is the number of blood cultures which were reported as contaminated divided by total blood cultures into 100. And we have kept the threshold at 10%. So if the blood culture contamination breaches 10%, then it calls for corrective action. Then critical alert communication, transcriptional error, registration rate, and report error rate. So how does these KPI help in diagnostic accuracy and efficiency? So all of the KPIs or a few of them should be monitored monthly, or you have your own definition. It can be 3 monthly, it can be once in 2 weeks. And this monitoring should be represented in the form of a run chart. The run chart should be available in all the laboratories, and all the technical staff and doctors must know how to read the run chart. So a specific and designated threshold should be set for these KPIs so that you do monthly analysis and you guide decision making and do root cause analysis. For example, we have a threshold for rejection rate of 3%, a blood contamination rate of 10%. So anything, and an EQUAS conformity less than 90% is a KPI for us, and we have to act if we are out of these KPIs. So these threshold definitions are an essential measure required for an adequate, informed, and complete utilization of KPIs. The laboratories can set threshold as per your convenience. You can have your own threshold. There is no guideline that you have to establish this as threshold. And these thresholds need to be periodically reviewed and monitored. So this is one of the run chart from our own lab. You can see that the critical error communication rate, which is the gray line, which is the straight line, is at 100%. So we found that all the critical alerts were communicated. What you see in orange is the blood culture contamination rate, and we have a threshold of 10%, and you'll see that at many points, in most of the points, our threshold is higher. So that is an area where we are working on, that our blood culture contamination is consistently above the threshold that we have set, and that requires that we train and retain all the residents who are collecting the samples. And our sample rejection threshold we have kept at 3%, and we find that at 2 points we had a higher rejection rate, for which we did the root cause analysis. So how to use this data? The threshold, as I said, the rejection rate is 3%, and whenever it exceeded 3%, we took corrective action. We have tried to understand why the samples were rejected, and we trained the phlebotomists, trained the registration staff, talked to the residents and the clinicians and the laboratory attendants. For blood culture contamination increasing 10%, we have done the root cause analysis. Since this is an area where there's a lot of residents coming and going, a new batch of residents coming to take the samples, this is something which we have really not been able to tide over, but this really calls for continuous root cause analysis and quality improvement based initiatives, and the trainings are mainstay for. So any deviation in critical alert communication rate, transcriptional error, and report rate requires root cause analysis and corrective action. This is our EQUAS performance, and you'll find that we have set a threshold of more than 90% conformity, and you'll find that in all the cycles of PT provision, we have been above 90%. We just escaped narrowly once, it's 90.57, where our gram stain finding didn't conform to the report which was provided by the PT provider. So anything which falls below 90% is a serious breach of KPI, and we need to look into that. So how does it improve accuracy and efficiency? Improving all factors that affect these phases in laboratory help in streamlining the process of test requisition form completion, adequate and correct sample collection technique, internal quality and external quality assurances, equipment, actual sample testing with final result entry, reporting and TAT of that sample. All these steps together increase the diagnostic accuracy and efficiency if monitored continuously. So the end goal of KPI is to improve the system, to increase the diagnostic accuracy. It's a collective team effort. It may require extra effort, but knowing the area of improvement is a huge game changer. Bringing to a certain threshold may take time and patience. Without KPIs, we will continue working, but we will not know the areas where we can improve. So set KPIs with thresholds of your own choice, but include all the phases, the pre-analytical, analytical, and post-analytical in your workflow. Thank you.
Thank you so much, ma'am, for this informative session. Ensuring a safe working environment is crucial for accurate diagnosis and maintaining safety standards. To elaborate on this aspect, We have with us today Dr. Juhi Chandra, consultant pathologist and laboratory quality assurance expert. She has more than 28 years of experience in the field of laboratory medicine and heads the Department of Laboratory Medicines at Jeevan Anmol Hospital. I would like to invite her on stage to please share her valuable insights on laboratory safety audits, improving patient safety practices, and occupational safety. Over to you, ma'am.
First of all, let me thank the team of NHSRC, with whom I work very closely as an external auditor also, for giving me this opportunity today to be here and share my views about how to go about auditing the lab for safety. So first of all, tell me something. Are we comfortable in this room? We are. There is good air conditioning. There is adequate space to sit. The chairs are comfortable. And that's how we feel that this is a quality place, because we've been talking about quality all the while. So quality is known by its absence and not by its presence. So if there was something wrong with the air conditioning or there was some noise coming from somewhere, we would say there is no quality. But since everything is in place, we are happy, and we are not kind of commenting that this place is good quality. We would have commented that there is something wrong with the quality of this place had there something being wrong. So it is very, very important to understand that quality is ingrained into the system, and quality is a voluntary process. You look for quality, you want quality, and it is your desire to have quality. So having, to audit your lab for quality is again going to be a desire of the person who's running the laboratory. Because if that initiative is not there, if that voluntariness for quality is not there, you will never go ahead for it. So today I'm going to be telling you about the various quality practice, safety practices, which have to be, inculcated into the lab environment so that everybody stays safe. And then if we talk about who are the people who we want safe. First of all, the lab staff. Next come the patients who are visiting the lab. Then the attendants who come with the patients, and there are other visitors also. So we need to have safety for everybody who's visiting the lab. And the safety starts from outside the lab. You have to have a way in which the patient comes into the lab. So what I've learned from the NQAS audit that I do, that you have to have a comfortable ramp with side railings to enter into any laboratory, so that even the differently able people are able to come to the lab and they do not have any safety risk. So risk can be in many ways. Madam just told us about risk. Risk is a very, very important component of ISO 15189 2022, which is the latest standard which is to be applied in the laboratories. So these labs have risk management or risk assessment indicated at 82 points in the standard. At 82 places, they're asking for risk. So nowadays, we don't talk about preventive action, because preventive action only happens once a non-conformity has taken place. A patient falls, he has an injury, and then we will take a corrective action, and then we will take a preventive action. But then you have to take a, do a risk assessment now, according to the new guidelines, even before the patient has had a fall. You have to imagine that, yes, the floor is very nice and glossy and granite, beautiful looking lab, lovely place, wonderful full frame glass. But what happens? Somebody goes and hits his head. Why? Missed out the glass. Why? It was so transparent. So you have to have something over there to be able to indicate. So risk is something that you have to look at. And risk in the laboratory comes in many shapes and sizes. And you have to look for biosafety, chemical safety, electrical safety, mechanical safety, and fire safety. So all these aspects which are a part of the lab have to be taken into consideration whenever you are planning to audit your lab. So this audit is very important for identification of the risk. We have to imagine the risk. We always imagine the risk whenever we are doing something. But do we document it? We don't. So now the latest thing is that you have to first think of all the risks that are there, and then you have to document the risk. And after documenting the risk, you have to think of a planned action after that. That, okay, this can happen, then what should I do? So if you have a very glossy granite floor, as I was telling you about, which we did the mistake when my husband made a house, we had granite put in the driveway. And then suddenly we realized that there is a clinic also. So the patients are going to come in. If you fall yourself, it is okay. Your mistake, your house, you fell. But then if a patient comes to your clinic and he falls because of a glossy granite surface, then you have to pay for his medical treatment also. And it is not done. So the next thing that we got done was sandblasting. So now first we bought expensive granite, got a glossy finish done, and then we got it sandblasted. So double the cost. So you have to think of all the aspects involved, and this risk has to be done even before, because the risk of, the cost of the sandblasting would have been lesser as compared to the treatment that would have been given to the patient and the court case that would have followed afterwards. So you have to identify the risk. You have to look after the regulatory compliances. You have to have a culture of safety. So culture is not like the culture madam is telling us about in microbiology. The culture is that the system that you have in your lab, how your staff knows he has to wear his PPE, how he knows that he has to be not recapping the needle, how he knows that he has to discard it directly into the sharp box. So that is the culture which your staff should be following, so that we do not have any risk to the safety of the people who are working in the lab. And then resources have to be optimized. Dr. Jain Srivastava sir definitely told us in the very first lecture that resources are very, very important. Resources in a private setup may be different from the resources which are available in a public setup. So then we call it jugaad. Whenever I go to audit, I'm also an NABL assessor, just for everybody's information. So when we go for an audit, we ask for a sharp container. So then we also have the people who go for home collections. So very beautifully, they show us a very nice BD ka sharp container. And then I asked, what is the cost of this container? 200 and something rupees. So I said, you carry this sharp container every time that you go for an audit. And how many needles will be able to fit into the little BD beautiful sharp container? Nobody uses it. It is only shown to other assessors, this is the sharp container I'm carrying. So then I said, jugaad. Jugaad in India is a word we use all the time. Jugaad is take a bottle. We have these reagent bottles which have a cap on it. Make a hole. Let the needle go in. It should not be able to come out. And that can be used as a sharp container in the laboratory. So whenever I go for NQAS audits, I'm always telling them, I said, you take a 5-liter can, take out the top dhakkan, there is another cap inside, make a hole in that, let the needles go in. Even if I invert it, the needle will not be able to come out. And then when it is 48 hours or it is 3/4 full, whatever is your protocol, cap it, seal it, hand it over. You're not supposed to disinfect it. So jugaad works, and the resources are optimized, because otherwise those 5-liter bottles, cans are only carried by the staff home, and they store water or other liquids in that. So to risk identification, I've already told you. First of all, in your lab, whenever you're planning a safety audit, you have to identify the safety team. It's a very good idea. This is also called as the quality circle. I will call it the safety circle. So you have a safety system in place. When the doctors were being attacked in Delhi by the patients, there was a team made locally by the local people. So, okay, this is my IMA representative. If something happens to me, somebody comes to my clinic, I'm going to call up this person. This person is going to call the next 8 persons. That person is good. So there was a team made, a quality circle, a safety circle that was made. You have to prepare a checklist. Checklist is very, very important. Even when we go to the supermarket, I'm sure either you make a checklist yourself, or you're given a checklist by your children or your husband or your wife ki ye sab leke aana. Why is that important? Otherwise, one small ingredient gets left out and you are at a loss. Please communicate all the safety requirements with the people who are working in the laboratory, and those are the lab staff, because they are at the maximum risk. So this laboratory safety training is very, very important. You have to train the people on the work processes that are happening in the lab. So what are the work processes? Number one, reception of the patient. Number two, identification of the patient. Very important, how to identify a patient. We ask the patient, Bhaiya, aapka naam kya hai? Ramdhan. So this old man who's hard of hearing says, huh? And then you take it that what he meant was yes. No, he was not Ramdhan. His name was something else. He couldn't hear you. And now you have identified his sample as Ramdhan. And that sample goes into processing, an error has happened. So you have to be very, very careful. Ask him, aapka naam kya hai? So if this fellow is not able to understand, sorry, this gentleman, I'm using the wrong word. If the gentleman is not able to understand, ask the accompanying guardian or ask him to show you some iCard to be able to positively identify the patient. Because I always say, if you're doing a test with all quality incorporated into it by state-of-the-art equipment, but you're giving the patient somebody else's report, everything is a waste. This is a diagnostic error. So we have to prevent that. So all these people who are working in the lab should be trained on the lab processes, starting from phlebotomy to the use of the machine, maintaining the machine, cleaning the machine, running quality control on the machine, identifying outliers on the machine. All these are part of the safety. And then again, we do inter-laboratory comparisons, or we do external quality assurance. And then again, we identify outliers, find out are our results accurate, are they precise, and in the end, is the correct result being given to the correct patient. Now we talk about general safety in the laboratory. You have to make sure that people not eating and drinking in the lab. Let me tell you, I do it also, off and on. There is no way out because we don't have a place to go. But then it should be an absolute no-no. You have to make sure that do the aisles within the laboratory have sufficient area of 36 inches for passing. Are any doors and corridors obstructed? Are stickers and signs posted to reflect the appropriate hazard on all laboratory equipment? So when we go for an NABL audit, a biohazard sticker, a cytotoxic sticker, how the MSDS is handled in the laboratory. Where is the acid kept? Where is the alkali kept? What will you do in the case of a spill? These are the kind of questions we ask the patient all the time. Sorry, not the patient, but the lab staff. Then emergency procedures. Are the laboratory personnel aware that they are to report all needle stick injuries, all cuts? Are they using appropriate PPE? Are they knowing where the PPE is available? Very often, if you ask them, can you show us the PPE kit? They'll take out the PPE kit. And inside the PPE kit, you'll have goggles and you'll have an apron and you'll have gum boots. And then you ask them, how do you use this apron? So this fellow is going to take it out. He's never seen it before. He's actually seeing it at the time of the audit. Then he'll open it. Okay, wear it. He doesn't know how to wear it. So it happens all the time. So it is very, very important that they should be aware of the emergency preparedness guide, which includes the chemical spill procedure. So this MSDA sheets, training of the staff on the same is very, very important. Then what all emergency equipment should be available in the lab? Safety showers, eye wash stations, and these should be checked that they're functioning or not. Let me tell you, 50% of the times I find that the eye wash is not working. 60 or 80% of the time I find that the emergency button in a walk-in refrigerator is non-functional. It's very interesting, but they make the emergency button and then you check it, it is non-functional. I have even found that in when we were doing online audits. So the lab person takes us very beautifully to the walk-in closet where the walk-in refrigerator, and he says, ma'am, see, we even have an emergency button. So he never thought I would do it, but I told him, I said, press it. He pressed, nothing happened. Only a non-conformity happened. So then they should be aware, which is the fire alarm pull station, the fire extinguisher, the exit staircraft, then the emergency gather point. These days, you must have seen in all hospitals, they have these gather points written. In case of an emergency, gather here. Then the chemical spill kit also, along with the MSDA sheets, which I've already mentioned. So chemical safety, you have to make sure, have all the individuals been educated about the chemical hazards? Are the safety sheets, I've already told you. The risk hazard, chemicals are labeled properly. This is very, very important. Their class and compatibility also. So are flammable chemicals, including chemical waste, being stored in an appropriate storage room or a flammable liquids cabinet? Are all chemical waste containers closed, labeled appropriately, and stored in secondary containment? And is the lab properly disposing of chemical waste? So recently, I went for an audit. Over there, we went to a very hi-fi, state-of-the-art histopathology lab. And the non-conformity given by my co-assessor from histopathology was that too much of inflammable liquid is being stored in the lab. Xylene, ethanol was all stored in the histopathology lab where it could have posed a risk. So it should be kept in cabinets which are specially made for flammable items. Biosafety. So you have to make sure that all biohazardous materials are labeled. Proper preservation and security of specimens should be there. Destruction, disposal of hazardous material should be authorized, supervised, handled according to the standard procedures. So having SOPs in your lab, and next training your staff on the SOPs, and somebody monitoring them on a regular basis to see whether things are happening or not. चीज होती है पर किसी को इस्तेमाल करनी नहीं आती, और जो यूज के जब टाइम चाहिए होता है, when you realize that the thing is not working. Recently, again, another audit, the fire extinguisher was high up there. I called a girl from the lab and I said, Beta, there is a fire over here. What will you do? So she said, Madam, fire extinguisher se band karenge. So I said, okay, get it. She said, Bhaiya. So I said, why Bhaiya? The Bhaiya may not be there. Madam, I can't reach it. So I said, that is the reason why I asked you to touch it. Then you ask them to pick it up and you will realize that they've never picked it up in their life and they're not able to handle the weight of the fire extinguisher. Leave alone, run it. So that I'll talk to you later. Then biosafety is very important. Ever since COVID has come in, we are all very well aware of molecular testings, and we are all very well aware that we need to have biosafety laboratories, BSL 1, 2, 3, and 4. I will not talk about it in detail over here because the time is limited, but all labs should be designed in a manner to be able to test what they're supposed to test. And higher levels of biosafety is required while carrying out procedures using higher risk group organelles, same thing. Sorry, this is a repetition nearly. Next is electrical safety. First time electrical safety came when NQAS came. We were asked, check the rooms, whether there are any loose hanging wires. NABL never taught me electrical safety, but NQAS taught me electrical safety. So very important, the lab is full of very complex equipment, and you have to make sure that they're not improperly maintained or worn out. The plugs are there, they're not kind of sticking in the wires. And those multi-point sockets should not have many equipment on one particular station. And higher voltage or currents produce a particular hazard. And you have to understand that water and electricity do not mix. So if your hands are wet, please do not switch this system. Next, we come to mechanical safety. In the lab, lots of things, centrifuges, autoclaves, hot air ovens. No one should operate any equipment in the lab unless authorized to do so. So authorization has come as a very big thing in the ISO 15189 2022. There is a separate sub-clause on authorization. Mechanical hazards such as are present, which are rotating equipment. They can entangle clothing, hair, or hands. You should never have fans in a lab. It should always be air conditioned because fans tend to cause drying. And drying of serum, drying of plasma can cause a lot of errors. If a centrifuge is not properly cared for, the rotor can fracture and the fragments become lethal projectiles. So very, very important, cap it while it's working, balance it properly, and then use it. Fire safety. Personnel should be thoroughly trained in managing fire and non-fire emergencies, such as large spillages, gas leakages, etc. Adequate fire extinguishers should be readily available. And as I told you, people should be trained hands-on. So when I go for an NABH audit or I'm checking an NABH file, all of you would be aware of the fact that you have to upload a video of the fire safety, of the fire training that you have taken. So the video has to be loaded, not just images of the fire extinguishers that are there. And everybody in the lab should be aware of the fact where the fire extinguisher is. And a mock drill should have been done off and on to make sure. Because fire, recently, about a year back, I think we had a very major fire incident somewhere in Delhi. And after that, we had the fire safety officials going around everywhere. So employees should be familiarized with all these things. Next, we come to biomedical waste. Biomedical waste is another hazard. We have to segregate it, we have to pack it, we have to label it, we have to handle and store it, plus it should be transported and it should be disposed of. The new biomedical waste guidelines given out in 2016 with amendments in 2022 say very clearly that whosoever is generating the waste will have to disinfect the waste on site and then dispose it off. That is something very, very important. There should be a safety officer involved. There should be daily inspection of the waste segregation, supervising and maintaining the registers. Chemical indicators should be used on a daily basis. Every time the autoclave is put up, chemical indicator, every week, a biological indicator to make sure that the autoclaving is good enough. You have to ensure the availability. So now here, you can do jugaad, but then even if you're doing jugaad, you have to ensure that the availability of all the things is there. So all the personal PPE that is required and materials like hypochlorite or bleaching solution, which the organization is going to provide to the employee, that is the safety officer and the lab staff, to make sure that we are able to disinfect everything on site. So cleaning and disinfection of work areas, another very important part which I learned in NCOS, that you have to check whether they're actually cleaning and disinfecting it using 1% hypochlorite. Process for decontamination and disposal, I've just told you about it. So now we are coming to the safety audit checklist. How much time do I have left? Okay. So this is a safety audit checklist which I have made or taken from somewhere. Obviously, I have not made the whole thing. So first of all, when you go in, this checklist should be with you. And when you're checking, you have to check whether the work areas are illuminated, the storage of the combustible materials, waste removed properly or not, are the aisles and passageways kept closed or are they open? Heavy items are stored in lower shelves. Materials to pick up the items placed in heights available, as I told you about the fire extinguishers. Exit signs displayed, paths free from obstruction, alternative exits available, fire doors not blocked, doors not locked. Fire exit signages should be there. And those should be, what do you call them? The ones which glow in the dark? Glow signs. So they should be self-illuminating so that just in case there is no light, people who are trying to get out of that place should know which is the way to be followed. Next is pits, floored openings, covered and guarded. Emergency planning, is it there? Fire extinguishers mounted near the doors, fire extinguishers unobstructed, fire extinguishers gas replaced, fire extinguishers tamper indicator. So all these, eye wash stations, emergency showers inspected, spill control plan is available, spill kits are available or not. Are there posters available for emergency action plans? Are the people having those posters of race and pass put up along with the fire extinguishers or not? Chemical hygiene plan available, respiratory protection procedure available, documentation of PPE, how much PPE is being used. In fact, in most hospitals, you have a hospital infection control in charge who looks after the fact as to whether people are using their PPE properly or not. Hazard assessment and training, emergency contact numbers, very, very important. And then checking for the correctness of those numbers. Very often you will find that the numbers are incorrect. Emergency evacuation routes posted. PP, again, eye and face protection, goggles and face shields, glasses and the possibility of a spill. Areas where eye protection required is posted. Open-toed shoes should never be allowed. So you should have closed-toed shoes used in the laboratory. So in my lab, coming in sandals and fancy slippers is not allowed. You have to come in closed shoes. Appropriate respirator used wherever necessary. Electrical cords in position, cover plates for outlets and switches, equipment accessible panels available. No exposed electrical cords. Multi-plug adapters have overload protection. Appropriate earthing is in place. Chemical storage, again, as I told you, whether they have adequate shelves, refrigerators, no food is added, is kept in that refrigerator, labeling, whether the containers are kept closed. Expired material has been disposed of as per the manufacturer's instructions. And before leaving, the instructions are posted and available. Flammable liquids used in well-ventilated areas. So if you're doing histopathology, say, so the grossing room should have a formalin check done, xylene check level fumes done, because this is looking after the safety of the person who's working in the histopathology section. The fire extinguishers, there are different types. The staff should be trained on them. A, B, C. Flammable liquids not stored near ignition sources. Compressed gases, just in case they are used, should have everything in place. Cryogenics, PP should be used, chemical used in good ventilation, containers vented or pressure relief devices provided. Waste disposal, we just spoke about it, and I'm sure all of you are aware of waste disposal. That is something which Dr. Malini is here and her team, they've been working on it, and we are all very well educated about it. So ventilation, that has become a new thing. So the number of air passes in the room, do we have ventilators up there? Very important. Ever since COVID came in, we started working on that. Pressure vacuum systems, just in case they are being used. So this checklist can be shared with you if anybody wants this checklist. I suppose Deepika is very, very helpful. She'd be able to, if Deepika I met. Okay, so you can ask for this checklist, we can share it with you. Security, doors to the lab operated, locked and closed properly. Windows are operated, locked and closed properly. Alarm systems are functioning. Keys and access cards are kept in the secure areas out of sight. Laboratory safety training provided to all staff. Emergency action plans available. Laboratory security training. Repeated, sorry. Laboratory orientation training, very, very important. Induction training is what we talk about. And all training should be documented, and you should have done a training assessment to see that the trainings are effective or not. So sir was talking about effective communication. Effective communication is a must. And effective training is the key to having lab safety. Awareness. So when you do a staff interview, what will you do in the case of an emergency evacuation plan? How to clean the blood spills? What is the location of the chemical hygiene plant? Who is the safety officer? Where are the MSDA sheets? What will you do? PP are you using? Simple things like elbow operated taps. Liquid soap is also very, very important for staff safety. Any carcinogenic materials, if you're using, you have to stop using, like sodium metabisulfite. We were using it for stool or cult blood. It has gone out of the lab. We do not use it anymore. Then where and how to use the emergency equipment. Handling unfamiliar visitors of the lab, which can be rats, which can be monkeys, which can be intruders. Aware of the lab safety policy. Anyone in the lab is conducting unauthorized research activity, that is also a hazard. You have to look after that also. It goes against the lab's policy and the safety of the information which is a patient's own right. Report suspicious or unusual conditions and security incidents to the public safety. Thank you very much for your time and attention.
Thank you so much, ma'am, for such a wonderful session. Clinical audits help in improving quality of care, ensure patient safety, and ensure medical practices meet standards. To shed light on this aspect, we have with us today Major General Dr. Jagtar Singh, VSM Director, Academy of Hospital Administration. With nearly 38 years of experience as a health and hospital administrator, Sir has managed and led diverse departments in armed force medical services. I would like to invite him on stage to share his valuable insights on clinical audits for diagnostic services. Over to you, sir.
Good afternoon, ladies and gentlemen. I have very tense looking people at the backdrop. They're managing the time. So what's the time I have starting now? Huh? 20 minutes. Okay. Right. So I could sense their, anxiety. Not to worry. I'll try to finish before that. Because my lecture is not going to be something which I'm going to teach you really very much. I would like some participation from you all also. And it's going to be a to-do session because that's what I'm going to tell you, what you have to do as far as your organization is concerned. We have had some brilliant expositions in the morning by Dr. Srivastava, and I would say from Air Commodore Rajan Chaudhary, and then of course a new lab that we discovered today, that is the PML, the owner of PML, and of course Dr. Juhi Chandra. That's lovely. So my task has been made greatly easy by the kind of landscape that has been set by these wonderful experts. So what I am going to do is, don't pardon me if I refer to some of my notes, because I've made some copious notes listening to them, and I may refer to them. Such great learning. So what are we all looking at? What is our aim that, we all are working for, right? And we are all working for, to make our healthcare organization safe. Now, not only safe for the patient, but safe for everyone who is coming in and out of that organization. It may be safe. It has to be safe for the healthcare providers also. It has to be safe for our other stakeholders like the families, the NOK, everything, right? So that is the aim, and that is what we are all working for. And that is where I would say the beautiful kind of standards which are there in NQuas, they give us a framework on which we can, work within and get that results that we are looking for. So that is what Dr. Srivastava laid out for us, and that was a wonderful. So before I really launch on into all this, I would, especially thank General Kotwal for engaging Academy of Hospital Administration in this exercise. It's lovely to be here, and for Dr. Srivastava, so on insisting that I do come and, talk to you people, because I'm basically a very operations guy, and that is what I would love talking to you. So the thing, as far as the patient safety is concerned, or a subset of it, as we call it, the diagnostic safety is concerned, all this starts back at the time when the first monograph on this subject came up in 1999. That was "To Err is Human, Building a Safe Healthcare Systems." That is what, that came out right in 1999. We have traveled a long way from that, but what
came up at that time was a lot of, emphasis on medication errors and those, errors in patient care. But there was not much, sort of looking at the diagnostic errors. What is the role of diagnostic services? What is the kind of safety that we have to ensure in diagnostic services? That was not really paid attention to, at that understandably so, because all the, the subject which is given to me is the clinical audit for enhancing diagnostic safety. We have been doing clinical audits in our healthcare organizations, but what we have traditionally been tackling, we have been tackling medication errors, we have been tackling hospital infection, we have been tackling falls, we have been tackling, needle stick injuries. These are the kind of topics that we have looked at. But have we looked at, the diagnostic safety and what is the clinical audit role as far as, our diagnosis services are concerned? So this has come up recently, and around 15, 20 years later, the same National Academy published another, treatise, which was said improving diagnosis in healthcare. Now, this was what drew the attention. It's almost about just 10 years back that all this focus has started coming on diagnostic services. So, having said that, right, I would move on to say this has been told to us earlier that it is said in this monograph also that which is the improving diagnosis in healthcare. It talks about that once in everybody's lifetime you are going to face or have to sort of undergo the consequences of a diagnostic error somewhere once in a lifetime. And these are the figures which are there each year. This was quoted by Dr. Srivastav also, that each year 1 in 20 adults will experience a diagnostic error in their outpatient setting, right? So now what is the, sort of challenge as far as the inpatient settings occur? It's almost about a 2.5 lakh harmful diagnostic errors occur annually. These are US, reports. So what you can imagine that this kind of problem that which exists in front of us, or the issue that exists in front of us, is definitely stupendous. It's huge. And we need to do something about it. And that is where all these things that we are talking about and deliberating about come in so handy. And that is where the WHO has also now, made this into a theme this year. Okay, now what is safety in diagnostic services? Right? Safety in diagnostic services, I would say, I would put it in 3 buckets as have been done. One is the laboratory medicine. That is the patient safety in laboratory medicine. Second is the patient safety in radio imaging. And the third one is the diagnostic safety of the physicians. Now, as far as the patient safety in laboratory medicine is concerned, it has been fairly well, elaborated by both the speakers or the experts who are in this field. So I am not going to go into too many details about this. Patient safety as far as medical imaging, I think you're going to hear about it in the next session soon, very soon. So I am not going to go too much into it also. But there is also a, key considerations for the physicians and their teams, because diagnosis is central to their professional identity. They have to make a correct diagnosis. They have to make, base their treatment on that. So that is a very, very critical issue. And that is what the patient has to feel safe about. That is where the trust part comes in, that once these things are right, that the diagnosis is right, his treatment is working out, that is how the reputation of trust of a healthcare organization builds up. Ultimately, it is your outcomes which are giving you the reputation in the field or in the healthcare ecosystem. So there are various challenges. There are, issues that we are going to look at. And as we go along, we will see how clinical audit plays into all this. Now, as far as NQAS is concerned, you have understood in that area of concern, you would all recollect, that is area of concern G, there is a standard which talks about clinical. What does it talk of? Anyone? Clinical audit. Outcomes. What does it talk of? G, what is the last standard which talks of? Clinical governance. Remember? I remember Deepika very, very passionately talking about it, clinical governance, because that was one of the new, when we did the course, we were told that, that was one of the newer introductions. Great. Now, what I want you to understand that is that clinical audit is a very important tool, which is there as far as clinical governance is concerned. And that is when I said right in the beginning, this is a to-do kind of a, dialogue that I am having with you. There is something which you can do. What you have been able to do in your place of work or in your organization or in your appointments would be looking at quality and patient safety. But this is something which you need to do. But the unfortunate part is most of us are not very clear how to go about it. What is it? We think clinical audit, it should be the purview of the clinicians or the people who are involved in care. No, I will just go on to tell you how you as a person who is on the ground looking at quality can play a very, very significant role, and how you can, get to this subject and make it into an institutional kind of an exercise for your healthcare organization. So we'll go on from here and see what quickly is clinical audit. What does it mean? This is a very kind of a standard definition by NICE. It's not a nice definition, but by NICE, that is the National Institute of Clinical Excellence based in UK. It says a quality improvement process that seeks to improve patient care and outcomes through a systematic review of care against explicit criteria and implementation of envisaged change. So now you see all that has been talked before by the experts, and they had laid a background to you, is all coming together in this clinical audit process, which you can do and sort of assess for your organization and make a plan of action or a path for the improvement of issues or your conditions or your situations or your care pathways as far as the organization is concerned. Now, what are the key features of this clinical audit? Just a basic understanding. It identifies the strengths and the weaknesses of the care, generates evidence for what can be improved, carries out meticulous data analysis, enhances patient safety. This is the bottom line of what it is supposed to be doing. Ensures medical practices align with established standards and guidelines. We talked about, standard treatment guidelines being there. Clinical protocols are there. Dr. Sangeeta Sharma is here, who have done very stupendous kind of work as far as the standard treatment guidelines are concerned in so many, disease profiles. So these are the kind of things which we need to look at when we are trying to improve, the care which is being given as far as our organization is concerned. What is clinical audit? It is not something which comes right out of the blue and we have to, take it like that, or something which is, kind of a backbreaking kind of a job that has been given to us. It is not. It is a part of the continuous improvement initiatives or the systems that you have in your, healthcare organization. It has to be taken like that, that it has to be institutionalized. Well, what are the, the clinical audit, steps which enhance the diagnostic safety? Now, what is the intent of the audit? Basically, it is again, as I said right in the beginning, it is looking at a problem, it is looking at an issue, it is looking at what is data available around that issue or a problem, and we have to find ways and means to, get ahead of that and improve it. So, there is no rocket science in trying to see what would be the steps in, this clinical audit. It is made into so much of a kind of a process that as if it is a very technical kind of a process. No, please take it out of your mind that clinical audit is a highly technical kind of a thing. No, it should form as part of your, job that you're doing as a quality improvement expert. So what is it? You have to find that the first step, as I would say, is if you look at it on the right side of the, can I have is there a pointer or something? No. There's nothing, it won't work on that. I think I'll leave it. So on the first step, if you look at the right side of the slide, is that you have to select a topic. Now select is a topic, and I would say this is possibly the most difficult part, right? You have to identify the problem. That is where, your role as a quality manager or a quality expert or the quality consultant comes in. Then you have to agree to what standard you would like to improve. Where do you want to bring that? To what degree you want to, solve that problem? It may be stepwise. It may be, intermediate level that you want to take before you reach on to the actual accepted state, national, or international standards or benchmarks. That is a decision which can be taken collectively as far as your, organization is concerned. You have to collect data around it, and you have to analyze the data against the standard and see where you are falling short. All this was also told by the two experts which came before me from the laboratory medicine sciences, that they are exactly doing the same thing as far as their area of concern, area of work is concerned, as in the lab. They are also having these standards. They are setting those standards. You saw how Dr. Purva was able to, set these benchmarks or these targets and see whether they are achieving it. That is actually part of clinical audit, which they are already doing it at themselves within that thing. But what is happening is this is happening at a departmental level. What you are maybe looking at is at the organizational level, how everything will come into play as far as the healthcare organization is concerned at that level. Okay. So what are some of the clinical audit topics you know? Selection of the clinical audit topics is very, I would say the crux of the situation. Can anyone just get up and tell me if you have done a clinical audit in your healthcare organization in the state services that you are working, what are the topics that you would have handled? Anyone? Yeah, please just raise your hand. Somebody can give a mic to them. Identify yourself and share your experience with others. Anyone? Don't tell me nobody has done a clinical audit till now. Yeah, medical audit, clinical audit, medical audit is part of it. There is nursing audit also part of the clinical audit. So the clinical audit is the broader kind of a thing where you look at, the other issues also, medical, nursing, paramedical, administrative, everything gets looked into as far as clinical audit is concerned. So give me an example of whatever you have done. Tell me. Yeah, just tell me. Maternal death. Okay. Right. Iodine in compliance. Okay. Okay. Antibiotic prophylaxis. So these are the kind of clinical diagnosis, clinical audits that you have done. Can you just briefly tell me quickly, how did you do it? What did you do?
For antibiotic prophylaxis, we basically collected the data that time of the incision.
Can somebody give him a mic? But it's visible.
So, sir, for antibiotic prophylaxis, we basically collect the data, like what is the time the antibiotic is being administered to the patient before the incision. So, firstly, collecting the retrospective data and then analyzing it with the.
Can you, before I do that, can you define the problem from which you were trying to do a clinical audit?
So basically, it came from the antimicrobial stewardship program that the different antibiotics have a different peak time. So from that, it came out that whether we are giving the antibiotics as per their peak time or whether we are using them rationally or not. So from that, we started collecting that, we started monitoring the time when the antibiotic is being given to the patient. So we saw that there is a lapse, the antibiotic given and the incision was done probably more than 60 minutes later when the antibiotic was given. So that problem was identified first, and then we.
What the point that I'm trying to make is that you don't do the clinical audit for the sake of doing a clinical audit. There has to be a problem on an issue, then only go into it, right? Okay, there are certain other activities which are going as part of your quality improvement program. Fine, those are there. This issue of clinical audit is also part of your quality overall efforts in your healthcare organization. But the difference is there is a problem that you are trying to look into or issue. So that is where the clinical audit topics have been medication safety, infection control, which I told you right in the beginning, patient satisfaction, adherence to clinical guidelines, and patient safety incidents, which are like falls, pressures, ulcers, and other adverse events. These are what the traditional things that we have been looking at, right? These are some of the clinical audit topics that we can tackle. Now, what are the topics which we can look specifically at a subset of diagnostic services, right? We are trying to shift the focus a little bit, right? And these are topics which I am actually looking at from whatever has gone before me by these experts, and they have said topics for enhancing diagnostic safety. You can look at diagnostic accuracy if there has been a problem in that, compliance to regulations and standards and SOPs, efficiency of your diagnostic processes. How do you optimize workflow? How do you, look at scheduling, your patient flow, your TATs, the use of resources, and overall operational efficiency. Now, see, from here we are moving away from what your, actual clinical work is into certain administrative, issues which are there, which are defining your diagnostic services. And sometimes the image of diagnostic services is not so much only dependent on the kind of outcomes or results that you are giving, but in the manner in which these are being produced and being handed over to the patient or made available to the clinicians. So continuity of care. So that is the fourth point I'm looking at, evaluates how well the healthcare providers coordinate and communicate during transitions of care. This is very important, such as patient transfers between departments and diagnostic guided interventions. When there is a handover from one kind of a department, let's say from lab to radio, radio to lab, or to nuclear medicine, how is that happening, right? Those are also issues where problems can occur, right? Any kind of an interaction which the patient has in a hospital, right, is fraught with the danger of something going wrong. Okay, so you have to plug those holes, and this is where the diagnostic safety comes in. Quality assurance program is at the governance level, monitoring for successful clinical audit. This is what I told you, right? You can have, a governance kind of a level committee which looks into clinical audit. There are places, there are, corporate hospital chains which have a very systematic, way of looking at the clinical audit, right? They pick up topics from various specialties, at various decided intervals. It may be quarterly, it may be 6 monthly, or it is yearly. But the same thing, in a way, you can also institute as far as your place of work is concerned. You can also do that. Decide on what are these specialties as far as your, area of work or area of influence is there. How many specialties are there? How many institutions are there that are, and set up a program. Consult your, people who are in charge of those facilities or look after the healthcare services, and decide a program in which you can institute or roll out this quality assurance clinical audit program. Now, these are the possible clinical audit questions in lab. I'm not going to go into this because these have been very, very well tackled by Dr. Dr. Purva Mathur. She has told you that there are issues, safety issues, or there are issues that we need to look at pre-analytical, analytical, and post-analytical, phases of the tests or the work as far as the lab is concerned. What I'm trying to tell you on this line is that from this 3 phases, or through these 3 phases, you can pick up areas or topics or select topics for your clinical audit, purpose. It is as simple as that. So you can decide on what is the problem that is happening and what is the issue which is evolving, and possibly do a clinical audit for that. Okay, now this is the possible clinical audit questions in radiology. I told you this is a lecture which will be coming up, right? But it is a similar fashion. You can pick up in this specialty in various, modalities which are available as far as radiology is concerned. It is a very highly technical, and a department with very, very sophisticated equipment now. And if there are any issues which need to be discussed, and, sort of looked at, you can look at these issues. These are lists. These, I hope that these slides will be available with the participants, I think. So this would be available. So they can go through it. I'm not going to labor on each one of them. But what I want to tell you, there are n number of topics, n number of fields on which you can work on, right? Okay. Now, this is an example that I told you that this is a clinical audit to enhance the diagnostic safety, basically TAT for, CSF. So this was a sample this is a study which was done in one of the hospitals, right, which, we were working on, I was working with, and we had this, nearly 1,500 CSF chemistry requests. They were analyzed. And we were thinking there was a problem, there was a kind of an issue which was raised by the clinicians about the TAT or the turnaround time by the time these reports were coming to them. So that is one area that we worked on. What I want to tell you is, it is not sometimes when you select a topic, it is only something which has to be coming from the clinicians or a clinical problem. Can you tell me what can be the other sources of getting your topics? Anyone? What are the topics? From where will you get your topics for clinical audit? Anyone? I know lunch is approaching and hypoglycemia must be at its peak right now, but you got another speaker, I think, after me. Oh, okay. Somebody made a very rational decision. Okay, I'll try to finish because then I'm standing in between you and your lunch. Quickly. Anyone? Where can you get these issues from your Yeah, great. So what work that you are doing as far as in your quality department or your quality thing, you will get issues from that. Your own quality data. What else? Huh? Patient complaints. Excellent. Right? Their grievances. You will get issues from that. What else? Exactly. Great. Surveys. Feedbacks. What else? Yeah, whatever records that you are keeping, your own data, which is your hospital data. That is another. You will have reports also for clinicians, right? There will be reports from clinicians also, which will come to you. So what I'm trying to tell you is there should be an outreach thing from your side to engage with those different specialities over a period of time to find out ki, what is your problem in that department, what is not happening, or what is there any workflow issue, or is there any material flow issue, or is there any information flow issue. So you can look at those things. And what else? One more area from where you can pick up topics. Great. That is the overall. What else? What else? Anywhere else? Huh? Yeah. Bataiye. Okay. Various areas which are concerned in the quality. That's what I said right in the beginning. Your own work will give you topics. But your medical records, that's another area. Incident reporting, that's another area. So what I am trying to say is that there is no dearth of topics as far as clinical audit is concerned. It is not so much of a pain. You can pick it up, do it, and make that visible change as far as your healthcare organization is concerned. That's what it is. I'm not going to go into this diagnostic safety events because this has already been talked about. This again has been very well explained by Dr. Srivastava, so I am not getting into this again. And these are some 12 tips for a successful clinical audit, right? I don't know why somebody said that. I have also come across this. Why not 6? Why 12? Somebody wanted to make a dozen. So, but they are very, relevant topics, I think, just to make the understanding that it is a process which you should not be able to shy away, but be able to do and make it visible as far as your organizations are concerned for improvement. So this is what I would like to say in the end. Make sure that your clinical audit does not become a cynical audit, right? You are not trying to find faults. You're only looking at, things to improve, right? So your focus has to be there. These 4 F's, right? The focus has to be there. Selection of topic has to be there. It can be easily done by all of you. There's no problem on that. Facts, that is the data, gather around it. Don't talk in the air. Talk with evidence and, what is in front of you. What may be there in another organization may not be, true for you. You will have your own peculiar, your own, definite kind of, situations in your own healthcare organization. The idea is to move forward, right? The idea is not to, decry anybody's efforts in this quality, but you have to move forward. And the thing is, you have to move fast, right? And that is the journey towards patient safety. And it is not a journey which is one time, it's an ongoing journey. As we always say, quality definitely is not a destination, it's a journey. And so is your quest for patient safety. You have to be bothered about it day and night. And clinical audit, I feel, is a great tool which is available with you to make a difference as far as your healthcare organizations concerned. I have stopped. If the chair permits, if these young guys have some questions to ask me, I don't know whether they are permitted, sir. Jensen, can I call for some questions if they want? During lunch, okay. I think everybody is keen for lunch. I will also stop here, and so I only hope you have enjoyed this. Right? So I generally, when I ask at the end of my class, has everybody, understood? So there is generally a deafening silence. So it means only one thing, or two things. One, either it has gone in, or it has gone totally apart. So I only hope there's something has sunk in. The message that I want to give you is, it's not such a, kind of a hullabaloo that we make it. A clinical audit by the name of it. It is not only the purview of, not the purview of only the clinicians. You can find these topics, do it by taking people into confidence who want to make a difference in your healthcare organizations. So all the best. God bless you in the work that you are doing. Thank you.
Thank you so much, sir, for the outstanding session. I would like to take this opportunity to thank all the speakers for giving their valuable and knowledgeable insights with us all today. Thank you so much.
Now, I would request my colleague, Dr. Deepika Gaur, to present a token of appreciation to Air Commodore Dr. Ranjan Kumar Chaudhary, VSM, Advisor, Healthcare Technology Division, NHSRC.
Now I would request my colleague, Ms. Saujanya, to please present a token of appreciation to Dr. Purva Mathur, Professor of Microbiology, Jai Prakash Narayan Apex Trauma Center, AIIMS, New Delhi.
Now, I would request my colleague, Dr. Vinita, to please present token of appreciation to Dr. Juhi Chandra, Consultant Pathologist and Lab Quality Assurance Expert. Now, I would request my colleague, Dr. Chinmay Swain, to present a token of appreciation to Major General Dr. Jagtar Singh, VSM, Director, Academy of Hospital Administration. Now, I request all the speakers to please step down and take their seats.
Now I request Major General Professor Atul Kotwal, SM, VSM, Executive Director, NHSRC, and Dr. J.N. Srivastav, Advisor, Quality and Patient Safety Division, NHSRC, to please come up on the stage and launch the Coffee Table ebook by pressing the button of remote to raise the curtain. Thank you so much, sir.
This book is a walkthrough of activities held among different states during Patient Safety Week and the glimpse of national event of World Patient Safety Day 2023, focusing on the theme Engaging Patient for Patient Safety.
Thank you so much, sir. Thank you.
Now, I would request Major General Professor Dr. Atul Kotwal, SMVSM, Executive Director, NHSRC, for closing remarks.
Okay, thank you. Thank you for this opportunity. I must congratulate the QPS division for this. Sorry, I have been asked to give few comments now because I have a meeting in Nirman Bhavan at 2:30. In fact, I had already left, but I was requested that no, please come back. But then I asked my driver, he said it will take us 10 minutes. So I got 10 minutes to have my lunch and then to leave. Okay. So I'll also be short. I won't, stand between you and lunch. But first of all, I think it is really great to listen to all the speakers today in that panel discussion as such. It is a learning for me also. So I just noted few points which, one was that clinical decision support system is the need of the hour because we talk of diagnostics. We have talked a lot about, the errors in diagnostics, but sorry, I think it was. So, but over the years, what has happened is we have become very, very, very defensive in our practice, number one. Secondly, the reduced clinical acumen, reduce, need, or rather, by clinicians, many times clinicians want tests to be done first and then they see the patient. It's happening at all levels, from primary till secondary till tertiary. So there's a misuse of diagnostics also. There's a huge number of tests which are done which are not required also. We have not spoken about that today. So we are talking more of diagnostic as missing out on diagnostics. But at the same time, there's a huge number of tests which are being wasted. I think that is also a part of quality. We should also include somewhere to do the appropriate test at appropriate time for the appropriate disease, for appropriate and adequate diagnosis. That's, I think, should be the overall approach of quality. So I wish it would have also been covered, the misuse of diagnostics which is there. That's a very important point. And that increase the out-of-pocket expenditure also. And if you're saying we are providing free, it is increasing the cost of the government, which could have been used somewhere else efficiently and effectively as such. So that's why it's time to move out of standard treatment guidelines. It's time to go for standard treatment workflows, which include the approach to patient, which includes the diagnostics, which includes the drugs, which includes the management, which also includes the follow-up. I just noted down a few points, listening to all the experts. So thanks for your talk, which prompted me to think about this. So that clinical decision support system, which is eventually after adequate databases, we can link with the AI also. You leverage artificial intelligence now in your future, and that kind of system, because we talk of capacity building. Enough capacity has been built for all the healthcare workers during their courses, during their curriculum, which they have done for basic qualifications. If after that also capacity building is required, then whatever efforts we are doing, I don't think that will lead to much of change as such. That's why we need to provide them with something which is available to them immediately on the click of a button while they are seeing the patient without disturbing their own process. So that CDSS also needs to be integrated into all the health systems, actually all the portals, and available easily to all the healthcare workers at all levels, depending on the requirement of theirs. Other is this report notification system has to be there. So that we have talked about, listen to the reporting system, and also so that notification system has to be made. And looking from the system's perspective, we have to stop blaming an individual. So that blame culture has to go. I request all the states, also a lot of quality nodals are there in this gathering, and so that no one should be scared that this thing blame will be there, because we have to identify what are systematic errors, what are random errors, and what are negligent errors. So is it negligent errors? Definitely yes. You need to investigate and then take probably action also if there's a repeat negligence. But random errors because of cognitive or some other factors and all also can always be addressed. Systematic errors, you have to address the entire health system, strengthen the entire system to reduce those systematic errors. So I think that's the kind of approach which you need to look at the healthy health facility level. And this goes into into drugs also, drug prescription also. These two are linked closely. Capacity building I've already mentioned, but that needs to be buffered, this thing strengthened by the CDSS. Peer review is something which is very, very essential, and that's where the quality nodal's role comes in. The peer review of each and every one, and audits have been really explained very well. And so what kind of audit system you make. Leverage technology now instead of doing each and every audit separately as such. How we can have a real-time kind of thing from various portals and databases. We are trying to now integrate all the portals and apps. So with that, we'll be linked to the various dashboards, where on real time probably you can, with HMIS coming up and the ABHA ID and HPR and HFR coming up and all getting integrated, we can now think of envisage how in real time we can make out who's prescribing what, who's giving what kind of diagnostics, what are the eventual diagnoses, what happens to the patient subsequently linked to the ABHA ID. We need to think of those systems now instead of each and every audit separately for everything. I'll just share with you one for the management part as such. What happens everywhere? There are pressures also on the individuals. I'll share an incident with you when I was commanding the hospital in Leh in Ladakh in 2014. And it was my second week of my command, and rather first week, end of the first week of my command. And the closed head injury case which came late in the evening. Obviously, we couldn't have evacuated to Chandigarh. The flights, there are no flights after 5 or 6 p.m. And my young surgeon and anesthetist, they did a closed this thing burr hole, because they said by morning it will the risk of coning, we'll lose the patient. I got a call next morning from the headquarters of Northern Command. I was under that. The Major General over there rang me up, who was my boss. I was a brigadier. That why you do the surgery at night for that patient and all. I said this was required. The treatment was required. Any delay we would have created an error. He said, "Agar kuch ho jata." I said, "That's part of treatment." But my surgeon was confident that it is required, and he did something, and the patient is all right. So that's a system which I'm talking about, that as quality nodals or as in state or in national level, we also have to empower individuals to be able to utilize their skills and their knowledge and their expertise to treat individuals as per their expertise at the right time, without any kind of pressures and forces that no, this is what has to be done, you have to refer this in case. And also we need to look at those systems also when we look at the quality as such over there. So I think I'll stop here just as one point in passing as such before I close off. Audit is something which quality people use. People like me in preventive medicine, social sciences, preventive social medicine, also social sciences background, and I spent 1.5 years in JNU also, by the way. We look at assessments. I don't know how you can start using this word assessment here, because there's a social audit which people thought when I joined NHSRC. A lot of foreign nationals, Johns Hopkins and all, wanted to do a social audit. I said, no, social accountability is something which we'll do. We don't want audit. Audit is something of tangible things, of building a wall or making a pond, which is done in Manrega. We should look at assessment. We got a lot of non-tangible, intangible things. But of course, but our clinical audit, something very, very specific checklist, the audit word is there. But overall, let's talk of, that's why we talk of national assessors. We don't talk of national auditors, which NABH says. And that's, I think, the beauty of NQAS over NABH is that we talk of assessments where we become part of the system, and we try to center the system as become part of the system, not as inspectors or auditors from outside. And I once again congratulate the QPS team for continuously, improving the quality of the healthcare facilities. And I think the credit goes to the state teams who are regularly interacting with their health facilities, assessing the gaps, ensuring that those gaps are filled up, providing enough support, and getting the certification process and all, which is a tedious, time-taking process of the strengthening. There are a lot of interpersonal issues also which come up when you talk of quality. The state sometimes feel that assessors are probably are negative. Assessors feel the state teams, sometimes the health facility teams are not that cooperative. So those kind of issues also you got to negotiate. And because that is also part of the quality team also, that quality certification also has to be quality, and that includes the interpersonal communication and commitment also at all levels. So thank you very much once again, and wish you all the very best. Jai Hind.
Thank you so much, sir. Now we'll break for lunch. Please be back by 2:40.
I request everyone to please be seated. We'll start with the following session.
We welcome back our guests from the lunch break. We welcome back our guests from the lunch break. As we resume our program, let's continue our technical sessions with the same enthusiasm and energy. I would like to invite all the speakers on the stage.
Please welcome Dr. Malini R. Kapoor, Professor of Microbiology, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Please welcome Dr. Anupreet Tandon, Senior Consultant Radiology, PSRI Hospital, New Delhi. Please welcome Dr. Deepika Sharma, Lead Consultant, Quality and Patient Safety Division, NHSRC. Please welcome Dr. Birendra Singh, State Quality Assurance Medical Officer, Gujarat. Please welcome Dr. Lakshmi Jiji, State Nodal Officer, National Health Mission, Government of Kerala.
Measuring the accuracy and efficiency of laboratories to ensure quality should be of a regular practice in alignment with the quality standard for a robust healthcare in the country. To elaborate on this aspect, we have with us today Dr. Malini R. Kapoor, Professor, Vardhaman Mahavir Medical College and Safdarjung Hospital. Her core expertise lies in systemic fungal infection, endemic mycosis, and biomedical waste and has over 104 publications. I would request ma'am to please deliver a session on importance of EQUAS participation for public health facilities. Over to you, ma'am.
At the outset, I am grateful to Dr. Srivastava sir, Dr. Kotwal sir for inviting me for this very pertinent topic. We are all from public health facilities, most of us, and we know the EQUAS participation. And we also are aware of the fact that Government of India is signatory to the Sustainable Developmental Goal in United Nations. And if you look at infectious diseases, AMR, they all come under Sustainable Developmental Goal number 3, and WASH, that is waste, water, sanitation, etc. They come under Sustainable Developmental Goal number 6. So it is very pertinent to have EQUAS participation in public health facilities. We are all aware of the fact that public health includes epidemiology, informatics, surveillance, prevention, effectiveness, and the laboratory is the central aspect of it. So, I mean, most of us, we are from the public health labs, and you are aware of the NHSRC and Ministry of Health and Family Welfare guidelines on integrated public health laboratories. And most of you are EQUAS assessors too. And these are the national quality assurance standards
for the integrated public health labs, and we are aware that India has a very high burden of emerging and re-emerging infectious diseases, and there is a high prevalence of non-communicable diseases also. And there is a mortality, high mortality, morbidity, and we have seen pandemics, and currently also one case of monkeypox. The second time, earlier we had 19 plus cases, and now again there is resurgence of monkeypox. Therefore, we need effective healthcare solutions also to control the existing diseases like HIV, tuberculosis, malaria, and control the pandemics and the emerging infectious diseases through cost-effective and efficient healthcare diagnosis and delivery mechanisms. And so we need to have cost-effective laboratory systems which are rapid, reliable, and accurate test results for optimal impact on patient care and overall health outcomes. So we do have a very good network of public health laboratories at various levels of healthcare facilities. And the epicenter of such labs is the district. And the IPHL, the lab providing comprehensive lab services, you have diagnostics, the ID diagnostics, which are in mostly in microbiology, along with other diagnostic services such as hematology, clinical biochemistry, virology, pathology under an umbrella, so that both the communicable and the non-communicable diseases can be diagnosed. And there is a data integration of different sections, different levels also. And there is vertical programs, and then you have the horizontal program. And these diagnostic facilities, they target both the communicable diseases which come under national program and the non-communicable diseases. So you have a disease specific approach also, and you have a vertical disease program also. And the vision statement is reduction in mortality, morbidity, and out of the pocket expenditure. We should, as Dr. Kotwal sir was mentioning in his, we should reduce the unwarranted test, the unwarranted expenditure by effectively preventing and controlling the diseases through rapid and reliable screening, early detection, and lab diagnosis of communicable, non-communicable, and other emerging diseases. So we need to provide a lab support, carry out the lab-based surveillance for infectious and non-infectious diseases, and of course, simultaneously, certain things of public health importance, the water quality, and of course, at the development of the point of care test. And recently, WHO has also released the point of care test, what are mandated, at least at the level of the basic or the public health facility level. And it needs to provide the technical support to block public health lab, and to support the block, conduct the training, function as a district lab for the various national programs, and provide accurate and timely data for analysis and research. And why we focus on laboratory data? Why, I mean, quality of lab results is important, because they are a major component in 70% of clinical decisions as per the US study. And if you look at, you have public health labs, you have the clinical or the hospital labs. One is testing the individuals, the other is on population. And therefore, and they are the capabilities of public health labs. You have certain at the national level, the reference lab, the state level, the tertiary level, the secondary level, you have the district level, and the primary, you have the block or the village level. And so these are the linkages, and you have the medical colleges, district level laboratories. And if you look at, I would say, like, these are the tests which are mandated, but they require quality in their reports. We are doing everything, and we have a very good network, but quality is mandatory, whether it's clinical pathology, hematology, cytology, biochemistry, or microbiology, and or the sample collection center. And then there is a weekly information flow from public health laboratory to a referral center also. And there are various kinds, everybody is aware of them. And if you look at, we could eradicate polio because there was a good, I mean, network of hospitals, the various public health facility across the country, and supported by their respective labs. And so we could do the surveillance and achieve this international, goal also, and national goal, of course. And there is a list of priority diseases requiring lab confirmation. They are epidemic prone diseases and diseases targeted for eradication or elimination. Then there are endemic diseases too. And then at the primary health center, we need to have the test for cholera, malaria, meningitis, diarrhea with blood. Certain point of care tests are recommended. For tuberculosis, it's smear. For again, a simple, like, RPR test for syphilis. And at the CHC level, certain tests are mandated, like again, smear for AFP for tuberculosis, malaria, blood smear for MP. And these all require, quality as a major factor. And then what are the objectives? What are the national quality assurance standards? Ensure the availability of comprehensive, accurate, rapid, and quality diagnostic services. Reduce the errors in lab processes and improve the efficiency of the treatment. Establish and improve quality management system. Ensure excellence in relation to the current knowledge and technical development in laboratory functions. So you have at the national level, the state level, district, and the facility level, you have quality structure and quality drivers are there. And there is a standard scheme also. This is under and then facilities have established internal and external quality assurance programs wherever it is critical to quality. Like the facility has established internal quality assurance program at relevant departments. Whether the facility has established external quality assurance program at relevant departments, again, the external, and then use of checklist is there, and then actions are planned to address the gaps observed during the quality assurance program, and planned actions are implemented through quality improvement cycles. So what is the expectation? You need to have precision and accuracy for your external quality assessment. And what is QCP? It's a quality control plan that is minimize the failure, detect the non-conformities, implementation of the corrective action. And purpose is for mitigation of occurrence of errors, appropriate the quality results of patients. Information is meaningful for clinical decision making. And what is quality control plan? Why it is needed? Like, it is needed when the quality control tools are surveyed, information is gathered for an RA, then QCP is developed or revised, it is monitored, and there is a checklist. So what is the aim of an external quality assurance program? To provide an inter-laboratory comparison, and for the external quality assessment, a system for objectively checking the laboratory's performance using an external agency or facility. So it is recommended for all labs, whether it's public health or it is private. We should be recommending for all labs, and it is mandated by ISO, and as per ISO 15189 standards. And basically your comparison of results with other labs, external quality assurance and the procedure is enrollment, participation, performance, and the sample is processed by person involved in the examination. And then you have an external quality assurance scheme, that is qualitative comparison with peer group or evaluation criteria. So you have checks, as you have seen in the morning session: pre-examination, examination, post-examination, and then which mimic the patient samples. You have a clinical challenge, and then it should also fulfill the ISO 17043 requirement. Now, communication with the EQUAS provider is also very, very important. It's not that you have asked, for example, for microbiology testing, we have various kinds of EQUAS centers, like you have at CMC Vellore for bacteriology, antimicrobial, resistant pathogen. Then you have at SGRH, that is Sir Gangaram Hospital, for bacterial and serological testing. And then you have a parasitology EQUAS, that is at Jepmer Pondicherry. Be in communication with your EQUAS provider. If they have not provided you the right, sometimes you find the sample contaminated. So you can be in touch with them, ask for a repeat sample, and clarification of any issue is also needed. Whenever you receive the EQUAS material, follow the instructions. The results are equally important because you all are contributing to the national data, the national program, whether it's IDSP or, and then PT or the proficiency testing, when the PT provider, they are sent, then the evaluation, then you analyze, receive the PT report, then if, the corrective actions, how they are taken. So every public health lab should have the management process involving the handling and analyzing the EQUAS samples, treating the EQUAS sample same as that of patient, because then only you can give the quality reports in patient care, monitor and maintain the records, investigate the deficiencies, manage corrective action efforts, communicate the outcomes, and then you have to discuss your results with the team. Information received from PT participation must be directed towards improvement in the laboratory to receive the full value. Again, it involves performance, precautions, and training. And record keeping is also very, very important. Results and what corrective actions you have taken if your results were not up to the mark, because it makes your lab efficient for accurate reporting, for national program disease surveillance reporting, IDSP reporting, and for pandemic preparedness also. So, but your proficiency testing results are affected by variables not related to patient samples, and PT will not detect all problems in the lab, and PT may not detect problems with pre and post examination procedures also. It has certain limitation also, but it will definitely make you as a diagnostic, laboratory one step ahead, and you are exchanging sample with other. If the EQUAS is not available, then what happens in that case? There are certain tests for which the EQUAS, the samples are not provided by the PT provider. There are certain, like the sequencing, like molecular sequencing, PT provider is not there. None of the centers will provide that. So in that case, you can do split samples, and you can exchange samples with other labs also, which are certified. And if I look at the government data, the EQUAS participation, I'm a microbiologist, so I asked various EQUAS provider to give me the government and the private split data, how much is the participation. So if you look at the IMM EQUAS, that is bacteriology and serology from Sir Gangaram Hospital, New Delhi, total participants are 840, out of which the government facilities, public health labs, participating are only 164. And similarly for the mycology EQUAS, PGI Chandigarh, out of the government, out of total of 189, the government facilities are only 78. That's a very, poor figure, but as compared to bacteriology, it's still better. Then for parasitology, out of the total 69, the government are 41. But if you take along the bacteriology, which is the most commonest sub-branch of microbiology, the participation is dismal, because these other mycology and parasitology are not there in other labs, in private labs, not as developed as in government. So therefore, the government participation is, is more in the rare pathogens, you can say, because fungal labs are less in private sector, or the parasitology labs are less. Parasitology, I'm talking of the high end, like which have, apart from microscopy, they have the other tests also, and few labs are doing cultures also in parasitology. But if you look at the bacteriology, which is the basic test, that is culture sensitivity, the participation from the government labs is very, very poor. Like it is totally 840, you just have 164 government, and rest are all private labs. So there is a need for urgent intervention here. I would request, like from Ministry of Health and Family Welfare or NHSRC, to encourage the government labs. So what are the issues faced? It is sometimes fund, sometimes, the knowledge. So that's, I mean, this is an offhand data. I just asked for my colleagues who are the PT providers to give me. And similarly, I asked Dr. Juhi Chandra also, and in pathology also, similar are the figures. The government participation is poor, so maybe like as a, you can say, directive from Ministry of Health and Family Welfare with NHSRC, it can go to all the public health facility, to those, I mean, you know, at least at the level of district hospital, all should participate. Then below that, some figure should come out, so that, you know, the quality reporting we are doing. So to summarize, EQUAS is a system for objectively checking the laboratory's performance using an external agency or facility. All laboratories should participate in EQUAS, whether government or private, but public health, it becomes, you know, it's our duty, so that we can contribute in the national programs and in the IDSP and other surveillance data, and we can be pandemic prepared also. So several methods of EQUAS are in use, and EQUAS samples must be treated the same as patient samples. So that's why EQUAS is very, very important. Since EQUAS uses valuable resources, and so make the best possible use, and it should not be punitive. These results should not be discussed with outsourced other agencies, and EQUAS should be viewed as educational, and EQUAS can help direct improvement in the efforts. EQUAS is a critical element of a quality management system, so all the public health labs should be encouraged and should be supported financially, and maybe in as part of Kayakalp. In NQuas, it is already there, but maybe as part of Kayakalp program also, when you're scoring the labs, you can give marks for that. And then the evidence-based information to use in planning, implementation, and monitoring and evaluation of public health programs. If your lab is EQUAS certified, so you can evaluate these programs, the infectious diseases better, and improve the performance of laboratories in support of disease surveillance and response. You can detect the outbreaks better. You can predict the public health events better. You can contribute to the national program by providing the right surveillance data, and you can also contribute indirectly to the immunization program if the disease incidence is high, for what all diseases, like for example monkeypox, till I think till last year end we had around 19 plus 4-5 cases, but this year again we have, but we don't have the vaccines available in India. The Geneos vaccine which is recommended is not available in India. So that kind of thing we can, if we equip our lab with better quality indicators and markers, and so you can have implementation of appropriate control interventions also, and it can act as early warning of public health events, and it can also help in providing and formulating the guidelines on treatment and prevention policies and protocols at both the national and the regional level. If you have a good public health laboratory providing the quality services, emergence and re-emergence of new infectious diseases. So thank you, everyone. Thank you. Questions?
Thank you so much, ma'am, for sharing your valuable insights with us. Now I would request my colleague, Ms. Saujanya, to please present token of appreciation to Dr. Malini R. Kapoor, Professor of Microbiology, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. I request you all to please keep your phone in silent mode. Those willing to receive a call may kindly excuse and move out. The specialized nature of radiology services, combined with rapid pace of technology advancements and the high volume of patient interactions, present distinct challenges for safety culture implementation. To elaborate on this aspect, we have with us today Dr. Anupreet Tandon, Senior Consultant Radiology, PSRI Hospital, New Delhi. Dr. Tandon is a dedicated educator, having served as DNB faculty, and her expertise spans women's radiology, including gynecology, obstetrics, and breast radiology. I would like to invite her on stage to share her valuable insights on practices for improving radio diagnosis for patient safety. Over to you, ma'am.
Thank you for those kind words. Thank you, all of you. Thank you, NHSRC, and greetings from me on World Patient Safety Day, where the theme this year is improving diagnosis for patient healthcare delivery systems. So today, I'll walk with you with the patient who has come with a health issue to a healthcare system. The patient has met the clinician who has made a clinical diagnosis and then written some lab tests and then some x-rays and more radiological investigations to aid the clinical diagnosis. So the patient comes with me, we go to the clinician, we go to the lab, give the samples with the patient safety as an utmost measure. And now, keeping patient safety in mind, I will take you into my department, which is radiology. Radiology earlier stood for only X-rays. Well, X-rays still form the backbone of our department. X-rays were detected incidentally by Wilhelm Conrad Röntgen in 1895 in Germany while he was working on the cathode ray tube, and he had that day covered the tube with a black cardboard so that he could eliminate light. Yet 1 meter away was a fluorescent wall which was covered with a fluorescent element called barium platinocyanide, and he found a strange glow on that screen. That got him quizzed, and he worked further, and he noticed he kept a pile of books and the glow was still there. Finally, he x-rayed his own wife's hand, which is very iconic in the discovery of X-rays. That was just an interesting story to keep you awake since we had such a sumptuous lunch. So, because technology has grown in leaps and bounds over the years, radiology has added many new facets and in fact is now known as radiodiagnosis and interventional radiology. So radiodiagnosis and interventional radiology is gradually stepping into the therapeutic domain as well. We see that in this picture, there is X-ray, there is CT, there is MRI, and then there is ultrasound. So we will step into the department and keep our eyes and ears and our sensibilities open to patient safety. The radiologist, as you can see, is bombarded with so many images and then has to also keep in mind patient safety in radiodiagnosis. Well, I have been introduced. I'm Dr. Anupreet Tandon. I'm a senior consultant radiologist at Mahajan Imaging, presently working at PSRI Hospital. So the importance of patient safety, since radiology plays a pivotal role in helping in diagnosis and treatment, and safety issues there could lead to harm and adverse effects. Hence, patient safety remains top priority in our department as well. History of patient safety, as you have been made aware, dates back to the Hippocratic oath we took, which we took the oath to do good and then, most of all, to do no harm. Primum non nocere is the Latin phrase which stands for first do no harm. Well, I'll show you the radiology department functioning. First, we call or physically go and take an appointment. The test is scheduled. And then we land up for the test. The images are acquired. Finally, the images are interpreted and reported by the radiologist and sent to the clinician. Well, adding here, I must add that AI is soon marching into our department and will soon be helping us further. To ensure safety in radiology department, three major factors have to be kept in mind. Firstly, the structure, the brick and the mortar. Second, the human factor, the staff, the nurses and the doctors dealing with the patient. And third, the machines. The machines could be ones with radiation or they could be without radiation. There could be tests which were using contrast or not using contrast. So, and these machines need to be constantly maintained and upgraded. I would add a fourth factor, the medicines. And the medicines are the contrast agents or the drugs which we used for providing local anesthesia for our guided biopsies or procedures. So coming to the brick and mortar that I mentioned, we will talk about the radiodiagnosis department layout. The department has its layout which needs to be certified by the AERB. Okay, and the certification has to be displayed for all to see. So the construction keeps in mind all factors of patient safety which are applicable in a hospital, which go on from the physical safety of the patient, the fire safety, the infection control, the seismic safety, electrical safety, and finally, specific to our department, the radiation safety and contrast safety, or the drug safety. Coming to the human factor, well, you cannot do away the human factor. Patient comes to the reception, comes for an appointment, gets himself or herself registered, and is prepared for the test. So the identification and verification make sure that the correct patient comes for the correct study, for the correct part and the correct side, and also gets the correct report. Patient identification and verification could be aided by putting color-coded wristbands. This should also maintain patient privacy. This should also aid or identify any risk factors, primarily such as pregnancy, because a pregnant woman or an unborn fetus is most susceptible to radiation hazards. Now, the patient has been registered, the paperwork has been done, and the patient is brought to the doctor who will do the test. So make sure there is effective communication between the patient and the physician with due history, informed consent, and risk factor assessment. We as radiologists make sure to check for any past imaging so that no duplication of unnecessary tests happen. And we try to avoid a radiation test with a non-radiation modality as far as possible. Coming to the machines, the radiation hazards, the technical maintenance and upgradation. Welcome to the radiation area. You will see these signs of radiation hazard on display on the walls. And when the machine is functioning, you will see this red light on. Showing you here on the right side top is an X-ray room and below is a CT room. With your introduction into the radiology department, I will take you back to school and discuss a bit on radiation physics to update you. So what is radiation? Radiation is basically waves which travel from place A to place B in either wave or particulate form. Radiation could be broadly classified into ionizing and non-ionizing. Well, we in our day-to-day lives are exposed to non-ionizing radiation every day in the form of light, in the form of radio waves or microwaves. But what we are dealing today with the safety concern is the ionizing radiation, and here in the radiology department, the X-rays. Types of radiation and their biological effects could be classified according to the particulate matter they carry, could be alpha, beta, gamma in X-rays, and neutron beams. You will note that the X-rays carry high penetration power. Again, to apprise you with some historical story, here is the picture of Marie Curie when she was in her 30s and later in her old age. She and her husband Pierre Curie worked in France and discovered radioactivity. They got the Nobel Prize along with Henry Becquerel for discovering radioactivity in 1903. They were the first married couple to have gotten a Nobel Prize. And Lady Marie Curie is inspirational to me because she's the only person ever to have got 2 Nobel Prizes for 2 different subjects. First, she discovered radioactivity, and second, in chemistry, she discovered radon and polonium. So Marie Curie was Polish in origin and had later shifted to France, hence the word polonium. So Lady Marie Curie, along, like I told you the story of Röntgen and the X-rays, it was in the same times in 1903 that she and her husband got the Nobel Prize for discovery of radiation. And not only did she do all this, she was also a war hero of the World War I. You know what she did? She was working on radium and the World War began. And she packed all her radium in a lead-lined box and she traveled by train to a place 375 kilometers away and put that radium in a bank locker, knowing fully well that France will win and she will come back and resume her research. And she went to work for the war. She played a very pivotal role because she used the X-rays there as portable X-ray units in small mobile vans, helping the surgeons in diagnosing injuries and helping in their treatment. So more about X-rays from Marie Curie as well. These, incidentally, these jeeps or the vehicles, they were called petite curies. Petite in French means little, and curies. So these vans were small mini vans of X-rays, hence they were called such. Her books are still there and they are still radioactive, so they have to be kept away in lead-lined boxes. Why I showed you her picture was because I was moving on to effects of radiation, and Marie Curie died of aplastic anemia, which later was thought that was an effect of radiation. Types of radiation could also be categorized as primary and secondary. As you can see in this picture, the X-ray is emitting the primary radiation and the patient on the couch is scattering it, which is the secondary radiation. More about a little bit about physics, the radiation dose. It's measured at 3 levels. It could be absorbed dose, or it could be equivalent dose or effective dose. Equivalent dose is with the radiation weighting factor, and effective dose is the tissue weighting factor. These are the units by which radiation exposure is measured: absorbed dose in gray and equivalent dose in Sieverts. This is an important, interesting slide, which I want you to look carefully. So a chest X-ray, which typically exposes us to around 0.02 millisieverts of radiation. It is almost equivalent to what we face in the natural background emission for 2.5 days. One chest X-ray, 2.5 days. One lumbar spine X-ray, you did AP and lateral, it exposes you to 75 chest X-rays. A CT head would emit about 100 chest X-ray worth of radiation, and a CT abdomen, 400. So keep this in mind as clinicians when you write any radiation test. Now, coming to the biological effects of radiation. If you are suddenly exposed to very huge levels of radiation, there could be acute radiation syndrome, or it could damage the cells, or further, it could damage the genome, which is the genetic damage. Exposing ova or sperm to unnecessary radiation, you could be dealing with congenital abnormalities, stillbirths, chromosomal changes. And these mutations could further lead to increased incidence of cancer in the society. Well, effects of radiation were laid bare in the grotesque, demonic display of science going out of hand at Hiroshima and Nagasaki. In 1945, World War II. Many people died instantly, but there were many who survived, and they are called, in Japanese, the word is called hibakusha. Hibakusha is the people who lived after and dealt with the side effects of radiation. Not to mention, they struggled with cancer and they struggled with many genetic deformities later. This to aid to your general knowledge, the devices used for measuring radiation. Showing you here is the penetration power of the various kinds of radiation, which shows the huge penetration power of X-rays, which can even penetrate concrete and could only be limited by a layer of lead. So this is an interesting slide which comes to practice in devising or designing a radiology department. This is a picture of a radiation room here in this picture, an X-ray room. So the bed in the center with the X-ray tube on top should be at least 2 meters away from the wall. If not 2 meters, if it could be 1.5 meters, but then proportionately the thickness of the wall would increase. So here giving you some figures to give protection to a radiation using unit. So for a 2 meter wall distance from the radiation source, we should have a brick thickness of 20 centimeter or plain concrete of 12 centimeter. A steel layer of 2 centimeter would do, or a lead of 1.5. Some lead-free shielding has been designed or developed by CSIR. So coming now to radiation safety. So radiation safety, number one is prevention. So prevention comes with to use a radiation modality as little as possible, or when it is absolutely necessary, use alternative imaging modalities as far as possible. And secondly, if we do have to use them, we should optimize the doses and use the principle of ALARA, where ALARA stands for as low as reasonably achievable. ALARA can be brought into effect by reducing the time of exposure or increasing the distance of radiation. And third, by providing shielding between the radiation source and the patient. Shielding is provided by various devices like lead aprons, neck collars, lead glasses, mobile lead shields, and lead barriers. Following here, showing you a picture of the lead apron that we routinely wear in the department with a thyroid shield. These are two technicians who are wearing the lead apron. And these aprons also have to be worn by the orthopedic surgeons in the OT when they perform C-arm procedures. So lead per se, this apron is very heavy. So it can be very uncomfortable for a surgeon working in the OT. So nowadays you have aprons which are very lightweight, which are made up of bismuth. Showing you here to aid your knowledge and recognize this is called a TLD badge. We all, doctors and technicians in the department, wear these thermoluminescent dosimeter badges, which are sent for regular measurement to find how much radiation we have been exposed to. Now coming to the medicine factor. So the medicines which we are dealing with is primarily contrast, and second what I mentioned was the local anesthetic agents. So contrast media is any agent which will be added to a study to improve the images. These images could be improved by natural media like water, or you insufflate air. So obviously these will not have any side effects, but you might have to use some chemical agents. These agents could be required to be used orally or IV. Or the IV agents could be CT agents, MRI agents, and finally they could be ionic or non-ionic in nature. So non-ionic agents are the safest to use. And contrast agents being administered IV at a very rapid rate to get the right images are prone to have certain effects. Some patients may have mild, some may have moderate, some may have very severe side effects. Mild side effects like nausea, vomiting, dizziness, anxiety, and serious side effects like arrhythmia, convulsions, laryngeal edema could happen. So we as doctors, we have to be constantly be alert when such tests are happening and see that our crash cart is ready and the nurse has kept it updated with the expiry dates checked, the defibrillator in order. Finally, we make sure that the equipment we are dealing with has been regularly updated with the quality assurance done. For radiation equipment, we could use automatic exposure control to reduce the time and hence achieve radiation safety. And of course, staff training and education goes a long way in achieving our goals. Staff training and education on regular basis on radiation safety and patient safety as a whole, keeping infection control, basic life support, physical, patient safety, and quality management systems plays a big role. Other concerns which are health concerns or safety concerns in the rest of the healthcare are common to radiology, including the fall prevention, the compatibility for differently abled or unwell aged patients, skid-proof flooring, wheelchairs, stretchers, and grab bars. A particular topic I did not make many slides of is the patient safety for MRI. So while taking consent of the patient, we make sure the patient is not wearing or not having any metallic implants or clips or any electronic devices. Many mishaps have happened when an MR room has been opened for a wheelchair patient and the wheelchair has been sucked in because the magnet is so strong. Similar thing with implants, and a patient has not given history, there's a pacemaker, it will get heated, it will move, the wires will move. So you have to make sure you have taken the history properly. Then fire safety, I will not repeat. Infection control, again, I will be repeating. Here is a slide showing 2 happy patients, of course, yielding to happy doctors, and finally, a happy healthcare system. So I put this slide because I found it very cute. Savdhani hati, durghatna ghati. So we should be always alert and make it doubly sure that we are not causing any harm to the patient. So knowledge comes from learning and wisdom comes from living. Thank you. Any questions? Although I'm not allowed, I think I have exceeded my time. One more topic which I wanted to touch was patient privacy. So many times we are dealing with diagnosis which does not have to be divulged to the patient. We have to sympathetically communicate the diagnosis only to the clinician or to the relatives. And simultaneously, there are other instances in which the diagnosis has to be kept secret. So we have to make sure that there are no attendants standing around, no GDA staff and things like that. So even patient privacy is of prime importance for security at times. Is that all? Okay, thank you so much.
Thank you so much, ma'am, for the outstanding session. Now, I would like to call upon Dr. Deepika Sharma, Lead Consultant, Quality and Patient Safety Division, NHSRC, to share their learning from the analysis of Sakushal self-assessment scores of facility across the country. With over 15 years of experience in the public health system, ma'am has played a key role in developing important technical guidelines and policies such as NQAS, Kayakalp, Laksh, Swachh Swasthya Sarvat, and the patient safety framework, among others. Over to you, ma'am.
Thanks, Richa. As we are talking about the patient safety since morning, and we know that patient safety is an important or critical component, specifically when it comes to the health system strengthening, as well as when we talk about the universal health coverage. But if we look into the burden of the care, or I'll say unsafe care, previous speaker has talked a lot about it, but I just want to quote a recent study which was published by WHO, which is basically Global Patient Safety Report 2024, and this report clearly mentioned that unsafe care is more than 3 million deaths per year globally. And half or more than half of these deaths are preventable. And further, the same report is reflecting that 2/3 of these harms are taking place in low middle income group countries. And further, there are certain estimates which shows that almost 130 million adverse events are taking place in low middle income group countries in any hospital setting in the low middle income group countries, and which contributes approx 2.6 million deaths. And as this year patient safety theme is about the diagnostic safety, and Srivastava sir has also mentioned about this in the morning, which says that approx 60% of preventable harms are because of the diagnostic errors. And previous speakers also talked about, when we talk about the diagnostic errors, it is not only the errors which is taking place in your lab or radiology department, it include the patient and doctor interaction, which may be in terms of the history. It may be while examining the patient, or maybe while interpreting the reports of the patients. India has started its journey for the patient safety way back in 2018 with the patient safety framework, and this framework was till 2025, and this framework has basically laid down the guiding principle as well as the 6 strategies for the country. We are not able to do much in these particular strategies. There are a long way to go ahead. But in continuation to the patient safety framework, every year we are celebrating World Patient Safety Day nationally with the theme in synchronization with the theme given by the WHO. The landmark in this particular journey was Sakushal, and many of you might be knowing that Sakushal is basically a self-assessment tool for improvement of the quality in public healthcare facilities, and we are more focused in secondary care institution, that is your district hospital. When we talk about this Sakushal, these are the standard as well as the measurement system, where under 4 areas of concern, we broadly check a hospital, and these are basically safe patient care processes. When we say safe patient care processes, it means we are talking about medication safety, infection prevention, prevention of harm to the patient, as well as to the communication.
We are also talking about clinical risk assessment, where we are talking about the safety in the general clinical processes, in specialist clinical processes, including RMNCHA and national health programs we are providing in public healthcare facilities. Next area of concern is safe care environment, where we are talking about the physical safety, we are talking about human and ergonomic conditions, environment, etc. And last one is the system for the patient safety, which means we are talking about the leadership, governance, reporting and learning mechanism, patient engagement, and ability to the point of care, which means having multi-disciplinary teams at place and having a mechanism of regular capacity buildings, particularly in terms of the patient safety. So in Sakushal, basically, we usually do a kind of biannual internal assessment with the team of the people, which is from the healthcare facility. And they, after conducting the assessment, they share these scores at the national as well as the state level. I just want to show you a little reflection, because we have started collecting the data of the Sakushal since last financial year, or I'll say 2023 onward. So you can see that in 2023, we have started with a very minimum number of the district hospitals, that is 237. And this year we are able to double this particular number, and we have 405 healthcare facilities which are assessed under Sakushal. If you look a little more further, you can find it out that there are almost 8 states which has basically done the Sakushal assessment in 100% of the district hospital, and it may have the 2 states like Telangana and Assam, which is a little bigger, but most of the states are the smaller state. Further, if you look into the blue bar, you will find it out that there are 12 states where the assessment is conducted between 70 to 99%. And the last chunk is basically the states where the assessment conducted are less than 70% of the district hospital. Now, in last chunk, there is variation, because you can see that at one end we have Bihar, where only 2 district hospitals are basically assessed under Sakushal, while in contrast, where we have UP, where 69 district hospitals are assessed. In UP, the denominator is 160, and we are feeling that still it is a very, very good number which is coming from the UP. If we look into the comparative analysis of 2 years, you will find it out that the median score in last 2023 was 61, and there is 2% improvement this year. And that is reflected in my patient care processes. But there is minimum, or I say no change in the 3 major areas, that is your clinical risk management, your safe care environment, as well as the systems of the patient safety. So we have to put our focus on these particular areas, specifically when we are talking about the Sakushal. Further, if you look into, you can see that, as I said, area of concern A, which is care of the patient, patient care processes. So under patient care processes, we are still doing good in terms of the medication safety and IPC, but we are lagging behind when it comes to the prevention of harm to the patient, as well as the communication during the care, which may be during discharge process, maybe during follow-up process, or intramural transfers of the patient. So these are basically the areas which we need to look into when we talk about patient care processes. Further, if I'll talk about clinical risk management, so under this also you will see that we are doing fair in terms of RMNCHA safety, but the same picture is not reflected when we are talking about the safety in general clinical and safety in specialist clinical services. In next area of concern, which is about the safe care environment, we will be happy that we are good in terms of hygiene and infection control and support and maintenance services. But the same picture is not reflected when it comes to the physical safety as well as human factor and ergonomics. So we are not at par in these particular areas. And if I'll talk about the last area of concern where we are talking about the systems for the patient safety, you will see that overall scores are not very promising. And in that also, we are not very good in terms of reporting and learning. We are not performing very well in terms of leadership and governance, and ability of the care, they are still underperforming. In fact, reporting and learning, I feel that this data is still little exaggerated because these are the internal assessment scores reported under the Sakal. Now, if we look a little more further, you will find it out that only 16% of the district hospital out of 405 are having more than 80% of the scoring, while 84% of the hospitals are having less than 60% of the score, or scores are lying between 60 to 70%. If I will look this comparison further with INQUAS certified facilities, you will see that the score in INQUAS certified facilities are better than the non-certified facilities. And that is also very well reflected when it comes to the different areas of concern also. Now, in the morning, everyone have talked about diagnostic errors, and they have talked about the definitions of the diagnostic errors. And I think these definition is very, very clear till now, but two things which people are reiterating again and again, that is that there are certain factors which affect the diagnostic errors. That is your cognitive factor as well as your patient practitioner encounter. When we say cognitive factors, it include the issues with the teamwork, issues in the communication. It may be biases, it may be fatigue, it may be stress, it may be clinical training and experiences, etc. Now, if I will look into the Sakal assessment, which is submitted this year, so you can see that in terms of the lab and radiology, our median scores are 74 and 70 respectively. But when I will compare this with overall diagnostic error prevention, which is basically specific to the lab and radiology, where we are talking about analytic, pre-analytic and post-analytic activity, here it is still better. But when I will combine this with ability at the point of care, which means multidisciplinary team, which means competency-based training, education, etc., the scores are very, very poor, which is 56%. And when we talk about the communication, again, communication during transition, you will find it out the scores are not even matching the overall median score of the country. So it means there are few things taking place in terms of diagnostic error prevention in specific department, but the same thing is not reflected in other departments. So we have to look the picture holistically when we are looking into the Sakal score. So at the end, I will conclude by saying that we need technique improvement. When we say technique improvement, Dr. Ranjan said in the morning that we required standard diagnostic procedure. We require a system at place where the equipment maintenance and calibration specifically in diagnostic departments are done regularly. We required a mechanism of the continuous education and capacity building. And when we saying education and capacity building, these training are supposed to be based on simulation models so that better decision making and skill building of the healthcare professionals can be done. Apart from that, we require the system where alerts can be given for the critical values. Personal change. So this is very, very much important. And when we say that a mechanism or a system where we can take the opinion of the second person about our result and also encourage multidisciplinary collaboration among the health professionals. Improvement in communication and teamwork. So foster open communication so that you can use various communication tool like Sabar, etc. Also, we required many things like training of our healthcare professional to identify and mitigate the cognitive biases. and also have a system where we encourage the reflective practices. Last but not least, of course, audit, feedback, as well as monitoring system for that diagnostic performance is very, very critical for continuous quality and safety improvement. I end my slide with a quote that safety doesn't happen overnight. It requires discipline, diligence to recognize and mitigate every harm taking place in the healthcare facility, because we are dealing with the lives. So I think we all understand that importance. Thank you. Thank you so much.
Thank you so much, ma'am, for sharing your valuable insights with us. Moving ahead with our session, we'll have a walk through the developments from states across the country. Gujarat's mission mode approach towards various health schemes like National Quality Assurance Standards and Sakushal have led to positive outcomes. I would like to invite Dr. Birendra Singh from the state of Gujarat on the dais to share his insights on implementing Sakushal, improving patient safety practices in healthcare. Sir is working as State Quality Assurance Medical Officer and helping state in implementing the focus strategy to achieving the targets set by Government of India. Over to you, sir.
Thank you. Thank you, QPS division, for giving opportunity to present our work. Slide is not changing. Okay. When I was preparing the PPT, this quote I came through. So it is very true saying that we cannot run from our mistakes, and our approach should be fair enough that our staff have place to recognize and respond to medical errors. So since morning it was talked that unless we report and recognize our errors, we cannot make a path for improvement. So with this view, I will proceed further. When Sakushal tool was launched in April 2022, we conducted a training session up to sub-district level, medical college hospital staff, DH staff, and sub-district hospital level in April 2023. And then started doing the follow-up with one of our intern posted in our cell, state quality cell. She came for 5 months. So we had given the project in the form of Sakushal tool, running the Sakushal tool in Gujarat. So she was very consistent, and we and our team supported her. She has done field visits also, and for consistently followed for 4 months to all the hospitals, and because of that we are able to do Sakushal self-assessment in 43 hospitals, out of which in 16 in medical college associated hospital, 10 in district hospitals, and 17 in sub-district hospitals. Score was in the range of 45 to 97 in medical college, in district hospital 50 to 91, and in sub-district hospital 36 to 89. The score itself gives a picture that yes, there was a need improvement, lots of improvement is needed, but yes, we can say that the assessment whatever is done was quite honestly it was done, because the score was as low as 36% also, and in district hospital also it is as low as 50% also. So at least we have some picture regarding the present status of hospitals in our Gujarat hospitals. When we further analyze the area of concern wise, out of 43, like in patient safety, 24 are scoring more than 70, 10 are scoring between 50 to 70, and 9 are scoring below 50. In same way, in safe care environment, 27 facilities are scoring. In clinical risk management, 29 are scoring more than 70, and in safe patient also 27. So numbers are around more than 50% are scoring more than 70. But yes, almost 50% are below 70 also, in the range of 50 to 70. Standard wise, also we had analyzed the scores of 43 centers, and in most of it's almost giving a same picture. So these are our major observations, like medication safety are ensured in most of the facility. IPCs are maintained, but hygiene practice, especially the hand hygiene practice, are still among workers. It's not that up to the mark. Then safe patient handling need focus. HR is well trained in emergency management. Spill management is also observed good. In clinical risk management, electronic paper record system are well placed. National health program protocols are strictly followed in DH, SDH level. Immunization services are well maintained. Mental and palliative care need more attention as a number of specialists are less. Due to that, mental and palliative care is also not much available, and shortage of specialists and staff nurses are there. Space and infrastructure issues are also there. Structural safety also needs attention. 24-hour running water is available at most of places, and wash facility practices are observed. These are the observations we analyze and taken out from the self-assessment tool. PPE and spill managements kits were also available. In patient safety, teams are still not formed in all the facilities. So we need to make a patient safety team. We are planning to change our state team name also and want to include the patient safety word in that. So capacity building and training, still we are working. Tomorrow we have one batch of 2-day training of infection prevention and control for district hospital, including ICN and hospital administrator. One batch we had already concluded of medical college, and from after tomorrow, next we will plan for sub-district hospital also. So multidisciplinary team at medical college we have, but at DH and at SDH level, multidisciplinary team is not available. So these are the finding. Some good practices which we recorded: automation in testing and recording, health infra, HMIS, Gujarat HMIS is also available there, and LMIS in laboratory is also functional, not centralized, but most of facilities have their own LMIS. Spill management is running water, pre-diagnostic screening, patient engagement tool, 5 moments of medication, telephonic follow-up, referral linkages are there, and one new initiative was done. Smart referral system was established all over Gujarat. We are planning for reassessment of facilities below 70% score. Sakusal is at least one lecture we include in all our quality trainings, so that we don't miss any opportunity to introduce Sakusal tool to each and every person we are calling for quality training. And we have the physical safety and infrastructure periodic consultation with PIU. Our most of up to CHC level fire NOC is made available. So we are working well in that. Besides that, we are working on maternal and child death audits, and we are trying, our team is trying to find out from the findings of maternal and child death audits, we are trying to find out what quality aspect and what patient safety aspect was missing behind the root cause of the death. So that we are working on that. Then we had made a strategy for liquid waste management in up to SDH level. So with PIU, we are planning for formation of ETP, STP to prevent the infection. Then we had published one tender in which we are inviting third party for infection prevention and sanitation audit. So, and that will include microbiological surveillance also up to CHC level. So the tender is at present ongoing. So a third party will be available for infection and sanitation audit for Gujarat from medical college to CHC level. So these some of the points which we are trying to improve in patient safety. We have one World Bank project also in which patient safety is included as a definition in 4 core definition. One of the part is patient safety. So we are dedicated and working as much as possible to provide safe care to people's getting treatment in Gujarat hospitals, public care hospitals. Thank you.
Thank you so much, sir. Kerala has been acknowledged for developing a successful model through its path-breaking work in community-based palliative care. To share the learnings regarding patient safety, I would like to invite Dr. Lakshmi Gigi from the state of Kerala on stage to share her insight on ensuring safety in palliative care at home. Ma'am is a public health specialist with over 11 plus years of experience and has worked as public health expert in state disaster control room in Kerala floods. Over to you, ma'am.
Warm good evening to one and all. And I'm extremely grateful to Jain Srivastava sir and the whole NHSRC team for giving Kerala the opportunity to present our palliative care system in this auspicious day. So it is like we are approaching towards the end of the session, and I am presenting the end of life palliative care trainings. It is a coincidence. And it's like on a tiring day after school, the people are eagerly packing their bags for in the last period, and the teacher is supposed to handle the class on a very important topic that day. So warm welcome to all of you to my session. So I'll be sharing my experiences from Kerala. As you know, the epidemiology of deaths due to diseases are changing globally. Now the new shift is towards the non-communicable diseases, and the non-communicable diseases is like it causes even more misery to the patient by contributing to early onset of terminal illnesses like stroke or CKDs, and make the patient go into the palliative care mode. So you all know that Kerala is facing an epidemiological or a socio-demographic shift in that sense also, and proportion of Kerala's population in the old age group, that is more than 60 years and above, shows an increasing trend from 6% in 1961 to over 13% in 2011. That is in a turn of over half century, that is almost doubled. And nearly a quarter of the total disease burden in Delhi is due to 4 NCDs: ischemic heart disease, stroke, COPD, and diabetes mellitus. And the top 5 causes of years lost to life include ischemic heart disease, stroke, suicide, CKD, and COPD. So there should be, in such a demography, there should be a synergy between the NCD care and the primary care-led palliative. So that is what my topic will be, and I'll be focusing on how the Kerala has evolved in the palliative care model, and what are the patient safety aspects that we look into this. And like in NCD, there is always the most important treatment, or most important care is like primordial care. There should be awareness generation, especially in the younger ones, and people should be motivated to come forward for screening, to get diagnosed themselves, to seek treatment, and also the most important part is to adhere to the treatment, and otherwise they'll be going to that deadly vicious loop, which will be causing them to more and more and more of NCDs. And coming to palliative care, it is always a patient-centric, the approach is patient-centric to enhance the quality of life. And there should be a continuous and comprehensive care. And the approach is, as I told, the patient-centric means for different patients, the approach should be different. For an end-of-life patient, it should be different. For a younger patient, because it is across all ages, it is there. And the sole aim is also to reduce the out-of-pocket expenditure which the family has to face while a patient, maybe an earning member, a young earning member, is down as a palliative patient. So coming to the major milestones that we had is in 1993, if you could see, the first movement for palliative pain and palliative care society was founded in Kozhikode district. It's a northern district in Kerala. And in the coming 12 years, from 1998 to 2000, the clinic started functioning with local community support in mostly northern Kerala, and initiating in a neighborhood network palliative care. That is, the people who are living in the neighborhood of the clinics used to contribute to the functioning of the clinic in means of microfunding, the raising of volunteerism, all those things. So, and thus the community-based organizations were developed for palliative care. From the time 2003 to 2007, you must be familiar that Kerala is having a decentralized system of governance. We have LSGDs, the local self-governments, from panchayats to block panchayats to municipalities, then corporations and all. They are having an active component in our healthcare. They are supporting us very well in the healthcare delivery. And few LSGIs started supporting the projects of these CBOs. And there was programs or the projects taken up by around 100 LSGDs for comprehensive palliative home care projects under their annual plan during that period. And the year 2008, so since more and more LSGIs came forward, the Assembly took care of the palliative policy of Kerala and was approved by the state government in 2008. And from 2008, the vision was to implement palliative care across all LSGDs. So the first phase was implementation of palliative care, how we can approach the patients who are lying at home to reduce their out-of-pocket expenditure, how to gather community support. That was the sole aim. And from 2009 to 2012, various measures had been taken by the Director of Health Service, Director of LSGIs to implement the policy. And after a decade, like after 10 years, in 2019, we have revised the palliative care policy as per the present needs. So this is our palliative care network, wherein the care starts from our arm SCs, that is the sub-centers, runs throughout the family health centers or the primary health centers to the block FHCs or the CHCs, then secondary palliative care units, and also to the tertiary or the medical colleges. And the most important person in a community palliative care project is a link person who provides the linkage between the family to the system. And they also offer the psychosocial support. So palliative care faced a major setback in the initial days of COVID because we were all wondering how to, mechanize our systems, how to roll out or bring back everything to normal. So routine medical and nursing care were given at home, but then we understood that there should be some other activities that have to be taken because nobody could go out because of the lockdown and all. And we could supply the regular medicines to their home through volunteers, telemedicine consultation, oxygen therapy at home with assisted devices, etc. All could be operationalized due to the network of palliative care that we already had in place. And in the post-COVID or the beyond the COVID era, we thought there should be revisions. As earlier suggested, it was in 2019 that the policy was revised. So high-power committees and working groups were formed by the state for implementation of revised policy throughout the state. An action plan, time-based, were prepared for different roles of stakeholders and when and what has to be completed. And the action plan was approved by the government in July 2023. So the revised plan was like restructuring of the palliative care activities at various levels, which I have already told. It starts at the sub-centers and last till medical colleges, improving the spectrum of services that we give at different levels, improving the quality of programs, and improving the area of coverage. This was the vision in the revised palliative care policy, and the quality of the program was stressed in that policy document. So the ARIKE means close to heart. Comprehensive elderly and palliative care program was thus revamped. And thus, as part of the action plan 2023, strong and active neighborhood network in palliative care was created in association with the Health and Wellness Center, which was the then Health and Wellness Centers, which was the auspicious project of the Government of India also. So we integrated that and we sustained the LSGD level home care with the support of CHOs and MLSP, or we call it as the middle level service providers at our state. And we delivered medicines, provide comforting devices, and sustain trainings at the centers. And at the secondary care levels, in spite of all what that is happening at the primary care, we also had inpatient care, provision of physiotherapy, and also monitoring of activities at the primary level, the hand-holding of activities. So that was for a more intense resource required setup was set up in the secondary care level where they could provide physiotherapy and IP services as well as to the patients. We had developed first referral units in Taluk hospitals where we had dedicated palliative care wards, and the patients were, the beds were earmarked for admissions for palliative patients, and divisions were developed in medical colleges also. We utilized the services of NGOs and CBOs also, and we incorporated the concepts and practice of palliative care in medical curriculum. Training and capacity building, including different levels of training centers. We also have each level of training center for corresponding level of healthcare facility. So coming into the sub-centers where the actual field work is happening, we divided the patients into 4 categories. In the category 1, the persons requiring palliative care, that the bed-bound patients. Category 2, the persons who are home-bound but not bed-bound, but they are having serious health-related sufferings. Category 3 are the patients with chronic illnesses but no serious health-related suffering. And category 4 are patients without chronic illnesses. So the category line list of category patients 1 and 2 were kept in the sub-centers and they were given direct care. The category 1 patients were given direct care by the community nurses, palliative care nurses who visited their homes. Category 2 were given support by the CHOs or the MLSPs, middle level service providers. They provided all those, and also ASHAs were mandatorily made to visit their households once a month. And they were ward level community volunteers who visits once in 2 weeks to provide general support to the patient and family. So what does the community palliative care nurse do at home is she provides the comfort devices, consults, teleconsultations, counseling of patient and family caregiver training, which was the most important because the caregivers are usually not trained or they are volunteers who assist the patients. And that is where the most of the patient safety incidents can occur. And then especially when you're dealing with a patient who has invasive Ryle's tube, catheter and all, the caregiver training is a most important component. So palliative care home visits we also included LSGD representatives like ward members, panchayat presidents and all in the team, and they could go to the home and see the social situation, what is happening there, and they could offer some help even by raising support from NGOs. So this we had already discussed regarding the category 2 patients who were homebound but not bedbound. And we also had some other integration with school and colleges for involving volunteers, because we know as the number of palliative care patients are more, we need more volunteers. So we identified schools and colleges with organizations for coming and helping the volunteers. And palliative care training centers were also developed and care homes were strengthened. And there is a program called Vayomitram for elderly, where they were taught the basics of daily living, like how to prevent foot ulcers, how to have a healthy, active elderly life, like that. And skill-based rehabilitation services, etc., were also given. So these are some of the photos that we, incidents that we developed in the volunteer training, rehabilitation training and all. So the most important one was the topic of discussion for today is the focused approach to ensure quality of care. How do we ensure that the care we are giving is of good quality? One, the patient and the bystander receives it as a free service. So just like what our ED and Atul sir told earlier, when we are giving a free service, the patient should feel that it is their right, and that should be, the system should assure that it is of good quality. So we conducted monthly review meetings involving the palliative care nurses to review their activities, how they are carrying out at the hospital level and also at the block level. Then 6 days training program for community palliative care nurses of primary care unit, 3-day training program, especially for taking care of the palliative patients for doctors, staff nurses, and field staff of primary care unit, and once a year review even with the LSGD representatives to oversee the approach. And in association to that, we should remember how we conducted the Patient Safety Day observance in Kerala, because last year the theme was engaging patients for patient safety, and palliative care was one such theme. And we conducted online sessions with palliative care providers and also the community-based nurses to improve the awareness. And online video tutorials were made, and different aspects of palliative care were also discussed. One about patient safety, beginning from the patient, then about the palliative care, pediatric palliative care patients, which is one area to be addressed. Then what are the conditions that patients have to be careful when they're having trials to catheter. All those things were discussed in that online training sessions. And we could engage the active participation of the ASHAs, and also state level webinars for community nurses, and around 750 nurses participated in the event. In this year, the theme is improving diagnosis for patient safety, and we are also conducting, as we told, we have palliative care wards, IP wards in taluk hospitals and district hospitals, and in association with that, we have in diagnostic safety, we conducted training sessions there, and we have active participation from the staff. So we thought, apart from this, we should do something different. And since palliative care in Kerala is one of the forerunners in that program, we thought of developing a palliative care quality assurance standards for Kerala. And actually, it is in the pilot phase, and we have established it in a few institutions. I'll just brief through what we have done. So why the need for quality assurance in palliative care we have already discussed, because we are catering to the terminally ill and bedridden patient who are helpless, and they don't they are at the mercy of the system or at the mercy of the caregiver, and it is the responsibility of the system to provide quality of care to the system. And based on the action plan, the quality improvement program in line with Kayakalp to be initiated for palliative care units at different levels based on accepted standards, and it was to be initiated by July 2023. So when we had a closer look at it, Kayakalp basically deals with infection control, sanitation, hygiene, biomedical waste disposal alone. But taking into consideration the overall targets given by Government of India, more and more number of facilities had to go for NQAS accreditation also. So we thought we'll move shift to NQAS pattern. So we developed standards likewise. When you were discussing, the previous speakers were discussing on Sakushal, the patient safety area of concerns are mainly care processes, clinical risk management, safe care environment, and patient safety systems. So we prepared a draft accordingly in February 23, and the assessment method was in line with Kayakalpa and NQuas. Standards were published and based on the GOs and guidelines that already we have, and discussions were conducted with palliative care coordinators in all districts, because NHM had supported the palliative care program by posting palliative care coordinators in all districts and trained palliative doctors and palliative care nurses for coordinating different LSGIs, because the community-based nurses are posted by the LSGIs and they are coordinated by NHM palliative care coordinating team. So the discussions were done and the quality standards were piloted in 5 primary units, 6 secondary CHCs, 4 secondary major hospitals, and 4 training centers in June and July of 2024. Changes as per suggestions were finalized in August 24, and state-level dissemination workshops were conducted. So the salient features of the quality assurance program developed for palliative care was the framework was indigenously developed by the palliative care team for the state, and it was supported by the Quality and Patient Safety Division. We had stressed on the psychosocial support aspect also, and the palliative care units are assessed instead of institutions, because the palliative care unit is a separate entity where there will be a community palliative nurse, there will be volunteers. That unit will be assessed, not the institution. Primary and secondary care units will be assessed separately. Institution which serve as the base for services will be given for considering the inputs. Only for the inputs part, the institution will be taken into consideration. Only the government-owned palliative care units are considered for now. And the emphasis was to know the unit's strength and weakness and understand what is the expected practices and the best practices going on. So these are the pictures of the consultative workshops that we had conducted, and we developed 5 areas of concern. As some of you might know, in our PHC checklist, right from the beginning, we had requested NHSRC to incorporate palliative care as one of the, in NHP, we have a section called palliative care. So taking into some of the standards from there, we developed a separate tool, which includes patient care, inputs, psychosocial support and community participation, infection control and quality improvement. So under the patient care, the institution should know the target population, frequency and timing, how are the home care planned, what are the home care activities that they do, how are the referral or specialist care they are doing. In secondary care, how was the integration with patient care happening? Regarding the inputs, what are the infrastructure available for the team, what are the human resources, logistics, drugs and equipment, all those things will be covered. Psychosocial support, what is the role of community, how do they give a psychosocial support, all those aspects will be looked into that. Infection control program, hand hygiene practice and antisepsis, all those just like what is there in Kayakalpa and NQuas we adopted there. And quality improvement, do they have an established framework, what is the documentation process, do the audits being conducted, monitoring and evaluation and innovations, because it is a community-led program. Every palliative care unit have a palliative management committee which is jointly operated by the LSGD. So that community participation is also assessed there. And we gave weightage for each area of concern like this. Weightage is different for primary, secondary, major and training centers, and the standards are developed, and there are separate checklists for primary palliative care units, secondary palliative care units, tertiary units and training centers. Then who will assess? Since this is a pilot phase, the internal assessment, just like what Sakushal does, we have asked the institutions to do, or units to do an internal assessment with the quality team of the institution will do the internal assessment, and we are opting for the second step as peer assessment at the block level and scale-up plan as district level and state level assessments. And how to assess is just like what we do in NQuas or Kayakalp, like observation, staff interview, client and community interview, records review and all. And work during the last 6 months was to be assessed, because the home care, there'll be around 10 to 20, less than 20 home cares in a month. So we took for 6 months total work to be assessed. And in this, unlike how we do for other accreditations, it is essential to go for a home care visit in peer assessment, because then that is where the actual work is happening. The institution, it is not happening in the institution, it's happening in the field. So we have selected 4 category of patients whose house has to be visited by the team. One bed-bound patient, one terminally ill patient, seeing a family of patient who had recently passed away, and a paraplegic patient. All these situations are differently to be handled. And the institutions are asked to do a self-assessment, do a gap analysis, conduct a gap closure, and go for reassessment, which will in turn aid the NQAS accreditation process of the institution as well. So coming to the way forward, so enhancing the healthcare professionals' training on palliative care principles and safety protocol is crucial for ensuring high quality, compassionate care. Why? Because the interaction between a healthcare professional and a palliative care or palliative person is less, but the healthcare professional will be responsible for training the caregiver. That is what the crux of the problem lies, because most of the caregivers are usually female counterparts or the spouses who may not know the basics of science. So we have seen persons with injuries in legs. When we ask, they are continuously using insulin syringes for 1 month. So it will cause injection because they don't know. We consider this as trivial. We assume that the patient knows, the bystander knows, but the actual truth is they don't know. A trained caregiver is an asset to the patient. So strengthening the infrastructures such as developing specialized palliative care units, improving access to essential medicines is vital for symptom management. Just like what Srivastava sir told, the major cause for disease burden across the globe is falls, and that is true for palliative care patients also, because falls can happen at any time. They can fall from the bed, fall during transit, fall during routine activity, fall while going to taking them to bathrooms. So maintaining the or assessing the safety risk at the house is of primary importance, and fostering a collaborative approach that involves patients, families, and caregivers can improve communication and decision making, because palliative person at home is a burden for the patient and also to the caregiver. So depression and mental trauma is one thing which is often goes unaddressed. So that can lead to suicides and other mental health illnesses. So that is also an area where we have to step in. Finally, leveraging technology for monitoring data collection can help identify safety issues and drive continuous improvement in care practices. The patients, as well as the caregivers, as well as the palliative care team should be encouraged to report incidents. Just as previous speaker Birendra sir told, they should not be afraid to report the incident. Only after reporting the incident we can do the correction, or at least we can prevent such incidents in other patients. So on that note, I am closing my speech. Thank you all for the patient listening. Thank you.
Thank you so much, ma'am, for this wonderful session. Now I would request my colleague, Dr. Deepika Gaur ma'am, to please present token of appreciation to Dr. Anupreet Tandon, Senior Consultant Radiology, PSRI Hospitals, New Delhi. Now I would request my colleague, Dr. Amrita, to please present a token of appreciation to Dr. Deepika Sharma, Lead Consultant, Quality and Patient Safety Division, NHSRC.
Now I would request Ms. Kajal to present a token of appreciation to Dr. Birendra Singh, State Quality Assurance Medical Officer, Gujarat. I would request Dr. Ruchita to present a token of appreciation to Dr. Lakshmi Gigi, State Nodal Officer, National Health Mission, Government of Kerala. Ladies and gentlemen, as we draw the curtains on this remarkable event, we want to express our deepest gratitude to each and every one of you for being a part of this national level celebration of 6th World Patient Safety Day. To conclude our event, I would like to thank our chief guests, all our key dignitaries, eminent speakers for the technical sessions, representative of Ministry of Health and Family Welfare, representative of all the state and union territories, representative from development partners, academic institutions, members who have joined us virtually, representatives from other division of NHSRC, our IT team, our admin team, and the team of India Habitat Center for taking out their precious time out of packed schedule.
At last, I would like to congratulate and thank the Quality and Patient Safety Division team members and my co-host for the event, as without them, this event would not have been possible. As we close, let's prioritize patient safety as a core strategy in the Universal Health Agenda. By fostering a culture of accountability, we can enhance healthcare quality and minimize preventable errors. Collaboration among healthcare professionals, policy makers, and communities is essential. Together, we can build resilient healthcare systems that prioritize every patient's well-being. Thank you, one and all.
Now, I request you all to join us for discussion in a delightful way with a cup of tea. Tea is arranged at foyer area. Have a great day ahead. Jai Hind.